Well, welcome everyone to our open mic contest for students. Students right from undergraduate, postgraduate, and even PhD. And it's a wonderful time, and it's really exciting to have all of you here with us. So, to start, I will just have to read our rules and regulations so that everyone is on the same page. The first set of rules are those for the contestants, and the main and very important one is that following the time limit of 5 minutes is essential. This ensures that everyone gets the same amount of opportunity, and also it ensures that finally, since public speaking is a main part of the open mic, it's always essential to be on time where you're public speaking. So it's keeping that in mind. In the allotted 5 minutes, the contestants will have to introduce themselves, mention the topic of the presentation, and share their screen if they are sharing slides. And for the rest of the time, I request all the participants to keep their cameras and mics off so that we don't have a disturbance. For the audience, you will find the link to vote on top of the chat. Now, you can go there. That takes you to our website. And if you just scroll down on that page, you will find that, in fact, probably already it is active. But please make it a point to actually watch the presentations and only then vote. Remember, you need your email to vote. And on each email, you can vote only once. So complete your voting once and for all, and only then hit submit. We have broken up the groups into groups of 5, although there's not that much of a difference. That is just so that while voting, it's easier for you to identify where everyone is and accordingly vote in that slot. And we will have a 5-minute break in the middle. uh, what else? Yes, definitely watch the live stream. Don't just directly go and vote this time, to be sure that everybody has actually watched and then voted. We are going to do a random check of the votes against those who were on at the live stream. And for that, we need you to definitely put in a comment. Either you put in your first name, your last name, your full name, but it needs to be there, with the exception of those who are our regular viewers and whose names we know. But if you are new, definitely you have to put in your name before you go and vote, because otherwise we will not be able to ensure that everyone has watched. So that is one more thing. And the voting will close at 7 o'clock. That is roughly when we will be finishing here. The website link is already pinned to the chat. And right, you can, the voting is broken into four groups, and you can tick as many as you want. It's not that you choose only one, choose as many as you want, whom you feel, because remember that the voting is anyway divided. There's votes, and there's also judges who are deciding. And of course, if there's anyone else you think who would enjoy watching this and who would like to vote, you can share the link of the video with them. The results will be announced tomorrow through our social media channels at Oral Pathology 360. That is our handle. And of course, here on YouTube as a community post. And the decision will be final, and it will be based on a combination with a 50% weightage to what the judges decide and 50% weightage of what the audience votes. So your votes count every which way. See and vote accordingly. What are the prize? The top prize, the three top presenters will receive certificates of achievement, and the best presenter will get a chance to present one video, one recorded video will be put up on our channel, and it will be there. So now coming to the judges, it's a real pleasure to introduce two people I'm personally very fond of. One is Dr. Kalpaga Selvi. She's a good friend. She's professor and head at Vedahi Institute of Dental Sciences. She loves teaching, part of the reason she's here, and excels at academics and research, and is very popular. She also has a lecture on our channel, which is among our most popular lectures, I must say. And the reason I said that I have brought some people who are popular and who love teaching as a whole is because we have a mix of topics today. It is not just oral pathology, and there is no spatial weightage to oral pathology topics. Please, this is something everyone knows. It is, in fact, how appropriate is the topic to a mixed crowd. So, this is the part of it. And welcome, Dr. Selvi. It is, as always, wonderful to have you with us.
Thank you, Mandana. It's my pleasure to be here. I look forward to this presentation.
Thank you. And coming to our second judge, Dr. Kushali Shah. She is a dedicated dental professional. She's assistant professor at KM Shah Dental College and Hospital and has numerous achievements, including being the winner of last year's open mic. And she was one of the two rising stars, and she presented a lecture in our international conference. So it is, she knows exactly what you're going through. So this is just that she feels and she knows exactly what this whole thing is like. So she is our second judge. Hi, Kushali, welcome.
Hello, ma'am. Thank you so much, ma'am, for the introduction. It's pleasure to be here with you, ma'am.
It's always a pleasure to have you here. Yes. So with that, we are done with all the introductions and we are ready to go. So for the judges, of course, I had given you the list of what the judgment is. It is a combination of the topic, the time, and the flow, and of course, the presentation. There is one small change from the list that I had given you. Our first presentation is now Swanand Patil. Before, he was number 19 in the Excel sheet I had given you.
Okay.
Yeah, that's the only change. After that, we will follow as the order. Okay, Swanand Patil, can you please put on your...
Hello,
Yes.
am I visible? Can I share my screen?
Yes, please.
Okay, is my screen visible?
Yes.
I'll start.
Yes, your time is already going.
Okay. Greetings to all. I'm Swanand Patil, second year undergraduate BDA student from Bharati Vidyapeeth, Pune. In face of difficulty lies opportunity. Well said by Sir Albert Einstein. In face of difficulty in form of medical emergencies, we as dentists should find opportunity to save lives. Before starting with the presentation, I would like to share some statistical data Adverse medical emergencies have been reported to occur at a rate of 2.5 cases per dentist per year, and as well said, even one life matters. So what is an emergency? According to ACEP, an emergency is commonly defined as condition perceived by a layperson on someone on his behalf as requiring immediate medical or surgical evaluation or treatment. These are some common medical emergencies that can occur in dental clinic. Coming to the first medical emergency, that is syncope. Syncope is sudden loss of consciousness. Vasodepressor syncope is common type of syncope that can occur. Stress being the primary reason of syncope, venipuncture, intraoral injection, as well as administration of drugs are some important causes of syncope. Signs includes dizziness, unconsciousness, nausea, and vomiting. Management includes laying the patient in supine position as shown in the figure, head tilt chin lift position for easy ventilation and artificial ventilation if necessary. Hypoglycemia is other such medical emergency. It is fall of BSL below 70 mgdl. Differentiation between hyperglycemia and hypoglycemia by the dentist is also very important. Signs includes weakness, dizziness, headache, and sudden unconsciousness. Management includes sudden termination of dental procedure, position, assessing the ABC. This will come in the presentation many a times. ABC is airway, breathing, circulation, administration of drugs, and oral carbohydrates. Next is anaphylactic shock. It is type 1 allergic reaction. Sensitizing dose is the first exposure of antigen, and challenge dose is the re-exposure when antigen antibody reaction is triggered. Generalized anaphylaxis are the wide range of clinical symptoms that may develop in anaphylaxis. The signs includes urticaria, arrhythmia, wheezing, and sudden collapse. I would like to mention the chemical histamine here, which is inactively present in the body, bounded to heparin. Management includes placing the patient in supine position, assessing the ABC, administration of epinephrine, administration of oxygen. Corticosteroids can also be prescribed here if epinephrine is not allowed. The next is seizure. As you can see in the video, the doctor is trying to safeguard the patient who is in epileptic seizure attack from all the sharp objects present in the dental clinic. So seizure is a disorder of cerebral dysfunction characterized by attack involving state of consciousness. The status epilepticus are the clinical symptoms or to which we refer as the seizure attack. Causes includes epilepsy, head trauma, infectious and vascular diseases. Management includes adequate ventilation. Usually seizure attacks are self-controlled, but if they're not, use of midazolam and diazepam. Next is asthma. Asthma is a clinical state of hyperreactivity of trachea. There are two types of asthma, intrinsic and extrinsic. The first being the allergic and the second being respiratory disorder related asthma. Status asthmaticus is the clinical symptoms. Management, placing the patient in supine, ABC, administration of bronchodilators like salbutamol, adrenaline, etephelin. Next is severe bleeding after tooth extraction. PEB, post-bleeding extraction, is the bleeding that continues beyond 8 to 12 hours. Local causes include soft tissue, bone bleeding, platelet problems, and coagulation problems. History taking is a very important part here. Gel foam, suturing, tranexamic acid injection, and cotton swabs are the management techniques. Airway obstruction. During dental treatments, there is a great chance of dental materials falling into the posterior part and into the pharynx subsequently, blocking the respiratory passage. Back blows and subdiaphragmatic abdominal thrust are some important techniques here. Angina pectoris, hyperventilation, and acute myocardial infarction can cause cardiac emergencies. Artificial ventilation, administration of nitroglycerin, adrenaline are very important. The doctor should be equipped with the instruments as well as the techniques of CPR and calling for immediate medical assistance. This is a summary of the list that a doctor should have that we have seen the emergencies. The main part, medico-legal aspect. The doctor should practice in his own specialty itself. I actually was a youth parliamentarian in Delhi for the last week and I presented a case and I have filed a bill in the Rajya Sabha this year regarding the medico-legal aspect of the doctors. I know I'm short of time, but I just need to mention this, that I was a parliamentarian this year and I presented a medico-legal cases regarding dentistry. This is my photo. So the dentist should be equipped with BSL, basic life support, and advanced cardiovascular life support as one life matters. These are the references. Thank you very much.
Yes, thank you for that interesting presentation. We go on with the next. The next presentation is from Ms. Uzma Almas. Miss Almas? Yeah.
Hello.
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 Yes,
Ma'am.
please share. You have a presentation, please share.
No, ma'am. I'm just gonna be orally speaking to that.
Okay, fine. Then I'm starting your time.
A very pleasant good afternoon to one and all present here. My name is Uzma Almas, studying Albert in first year Albert Dental College and Hospital, Kalburgi. My presentation for today is vision of growth in all aspects in individual growth, education, and professional practice. What is growth? As dental doctors and as dental students, we define growth is a mass of increase in the mass and size of the body and organ and personal growth. When it comes to personal growth, it is to identify, it is a process to identify the physical, chemical, social, and the spiritual changes we desire. And in to each working on each area to develop for our fullest potential. Individual development and growth when it comes. As a student, my experience to find my personal growth is in being in my studies, like listening actively, improving the time management, then developing emotional intelligence, developing the growth mindset, etc., to keep me focused on these points to achieve my goals. Boosting our confidence every now and then is important to make us grow and make us a better person in presenting our skills in our work and our studies. And whole perspective of this message is that I'm going to give you that C is equals to MV, a formula. I'm not going to define M has mass and V has velocity. I'm going to divide it as in my way. C is equals to concentration, M is equals to stable mental growth, and V is equals to velocity of the to keep up the work or yourself updated. Moving on to house growth in education, has taking our example of BDS, which is a 4-year course plus 1-year internship. As a first year student, it made a very good impact on me. As anatomy is my favorite subject, it then teaches the living physiology. You get to learn about the body and the chemical reactions. And biochemistry, it's just not all about the carbohydrates. It's a lot more. And ADH is a basic foundation for all the dental students. And for second year, third year, you have the posting, and final year also has the clinical significance and the 8 subjects which are important. And internship is a valuable tool for a person to develop its career, and then it provides practice development, skill development, networking opportunities, and you can say um, opportunities are more. And then moving on to the professional growth in dentistry, the thing is that dentistry is a skill-based profession. You just need not have a technical skills, but also moral values. Speaking about the moral values is how you communicate with the patient by having a positive attitude towards the patient and convince the patient to undergo a treatment or surgery by providing them information to why they have to undergo a surgery and a treatment. And the professional growth is seen in clinical dentistry also and non-clinical dentistry. Clinical dentistry is that it does not only under complete understanding of how a clinical techniques work, but also to set up a clinic and how it grows. It can be grown in such a way of social media by using the marketing skills. And you can see the growth can be seen in the clinical dentistry by the evaluation of the clinical trials, program trials. And when you come to the non-clinical setups, it is it provides a dental research, dental journalism, and dental education. When it is about the non-clinical, it is a job which is flexible option to many doctors, and it pursues experience and a career. Non-clinical job is something where you don't get to treat a patient or testing a patient. Dental research provides a good opportunity to the academics or focusing on the oral health sciences. And dental informatics is a field where dentistry and the information technologies combine together to form the development of the data science and software development of the dental sciences. So I want to end this with a very beautiful quote. A genuine smile comes within the heart, and a healthy smile should be taken care with a dental care. Thank you.
Yes, thank you for that presentation. Very innovative and different. That was nice. Now, just reminding everyone that your voting needs to happen on that link which is pinned to the top of the chat. And also, please remember to type here in the comments before you go there. And another thing is that Since you are here, please hit the like button and also hit the subscribe button. That supports us and ensures that Oral Pathology 360 shows up in different search engines. Right, so we go on with our next presenter, that is Miss Ekta Bajantri.
Good afternoon, ma'am.
Good afternoon.
Hello. Hi, hello, namaste, vanakkam, sasyakal. My name is Ekta A Bajantri. I am studying in first year BDS, that is Al-Badr Dental College. So today I have come forth being an enthusiast of open mic speakers or even a pick and speak speaker. I have come forth to put up my topic for today. So I have chosen a very basic topic, yet knowledgeable one, that is ethics. Ethics is nothing but the systematic study of moral principles, which provide knowledge about our profession and our personal life. It gives us clarity about what we should do regarding the decisions we take in our professional as well as personal life, about what decision is right and wrong for our life. And it also gives us physiological stability. Now, when ethics comes down to dental industry, I can say that it plays a major role in dental industry. It is one of the most important keys of dental industry. It decides whether the professional is into a profession or no. It plays a major role in deciding the profession of a professional. It is not just related to theory, because dentists are all practicals. We come which we do. So if we don't have ethics in our practical cases, if we don't have ethics in what we do, ethics are nothing but basic manners. So if we don't show ethics in what we do as a dentist, I can say that our profession doesn't hold ethics. When it comes down to ethics, we have to get knowledgeable and good at the same time. So I can say that either the ethics decides the honor of the profession. It is very important. We being the future doctors honor our ethics. And ethics is not just about being right or wrong. Ethics is always about choosing what's good for the patient, what's fair for the patient, being fair on the part of a patient. We being the service providers should know what is good for the patient and what is bad for the patient, and being fair in whatever we do. And according to the ADA, there are 5 fundamental rules which govern the ethics of dental industry. One of 5 of them are: first one, patient autonomy, which is known as self-governance; non-maleficence, which is known as to do no harm; and beneficency, which is also known as to do good by the patient; and justice, to be fair; and velocity, to be truthful to the patient. I can say all these aspects are a top tier of dental industry, but according to me, one of it is most underrated subjects. Example like veracity. Veracity is about truthfulness. The amount of truthfulness we can show to our patient being the service provider. It teaches us to be humble to our job. It teaches us to be down to earth regarding our jobs. Veracity also includes intellectual integrity. That is, we having a complete research about what we provide to our patient. If we are having a complete research and knowledge about the task we are going to put forth the patient and communicate with the patient regarding their needs and their adjustments, it shows that we are being a good dentist. And now, being a dentist, it's our duty to abide by all these rules and fundamental properties given by the ADA to us. So I would like to put up a quote that says, ethics is not just related to dentistry. Ethics can be compared to a tree which does multitasking. Its branches are useful, its trunks are useful, it gives shadow. Same as dentistry. Various aspects of the tree are like dentistry. Like, you can be skillful, intellectual, you can have wisdom, you can have everything. But what if there's no fruit on the tree? Like, example, if there is no ethics in your dentistry, it is equal to not having fruit in a tree, which is completely pointless. So me being a student of dental college would like to take up this opportunity and accept my dental ethics and abide by the rules and fundamental properties, so that my foundation of my budding career stands tall and firm. So I would like to say thank you for giving me this opportunity and end my presentation. Thank you so much.
Thank you for that nice presentation on ethics. Our next presenter is Anusha Ladi. Miss Anusha, are you there?
Yes, ma'am.
Okay. Please share your. Are you sharing anything?
Yes, ma'am.
Okay, share your screen.
Shall I start, ma'am?
Yes.
Good afternoon, everyone. Myself, Anusha Srinivasrao from MRDS Dental College, studying in BDS third year. Here I am to present you on a topic, tooth, a vital source of DNA in forensic odontology. So, this is the overview of the topic which we are going to see. Forensic dentistry involves the evaluation of dental evidence with the intent of assisting the administration of justice. It is more accurately called as forensic odontology. Father of forensic odontology is Dr. Oscar Ameda. Then, historic milestone in the forensic odontology. In 1995, Jeffrey et al. Used the radioactive probe to identify these mini satellites which to detect the fine pattern of these individuals. According to size, they are named as VNTR and STRS, that is variable number of tandem repeats and short tandem repeats. In 1991, Squaz et al. Under variable conditions isolated high molecular weight DNA from the dental pulp. Malware and in 2003 found a study that the pulp produced the strongest PCR amplification. Then, what does the forensic odontology do? They analyze the observation and observe evidence, collect the evidence, attend the accident or crime scenes. Then, what is the scope of this forensic odontology? It is used for identifying the unknown human records. It also used for the age estimation in both living and deceased. It is used for the analysis and recognition of bite marks found on the victims. It is also used for the gender determination and also used for the analysis of dental malpractices and crimes. So it is used in the civil, criminal, and research cases. Then what is this need for this identification? There may be a social cause, there may be emotional cause, or there may be a legal cause. Then why we have choose teeth? Because each individual has different individual set of teeth which can be traced back to establish the dental records. Teeth are the good source of DNA, including the DNA, dental pulp, and crust tooth, which can provide a nuclear or mitochondrial DNA, which helps to identify the person. Then methods of dental identification. There, firstly, visual recognition and personal effects or belongings. Nowadays, scientific and valid technique is fingerprinting technique, dental identification, and DNA techniques. Firstly, DNA fingerprinting. DNA fingerprinting was invented by the Sir Alex Zaxley. DNA fingerprinting is also known as dental profiling, which is used to identify the individual based on their unique DNA characteristics. Then, microsatellites, a short tandem repeats DNA sequence of particular locus on a chromosome, which vary in the number in different individuals. So it can be used for the genetic fingerprinting. Then it can be identified from the dental DNA also. It also can be identified by the DNA. Then what are the techniques of acquiring DNA? This include milling technique, conventional endodontics, horizontal sectioning of the tooth, and cryogenic grinding. Then what are the sources of oral cavity of the DNA? That may be a dental or saliva or oral tissues. Dental is from the pulp, dentin, cementum, and the bone, and saliva is from the desquamated epithelium. From the oral cavity, it may be the epithelial and connective tissue cells. Then mainly two types of DNA which are present. This is genomic DNA and mitochondrial DNA. In this picture, you could see that genomic DNA is present within the nucleus and mitochondrial DNA is present within the DNA sample which is obtained. Then distribution of DNA within the teeth. Firstly, enamel, which is the hardest substance which covers the tooth. It contains acellular. It is acellular. It is 96% mineralized. So it contains no DNA. Then dentine. Dentine is densely formed by the dentinal tubules. It contains odontoblastic process and nerve fibers. This contains the mitochondria along the length. So it makes the major source of mitochondrial DNA. Then dental pulp complex. It is also known as pulp. Pulp, which makes the major portion of the tooth, which is highly cellular, which is highly innervated and highly vascular, which contains the numerous cells. So it makes the pulp a reasonable source of DNA. Cementum, which has both cellular and acellular. The cellular cementum being containing of cementocytes, which becomes a good source of DNA. Then methods of dental age estimation. Firstly, dental age estimation is a method of age determination that uses the dental development and post-formation changes to correlate with the chronological age. Here is some method used to dental age estimation that may be pulp to tooth ratio, tooth formation, gustafson method, and panoramic ratio. This is the overview of this topic. Some of the famous personalities are also identified by this DNA method, that is Adolf Hitler, Thomson, Jefferson, etc. Then I could summarize that teeth offers a good, reliable, and often enduring source of DNA that can be crucial in forensic odontology, as it is most resilient. So, thank you.
Yes. Thank you for that presentation on forensic odontology. Interesting. We will go on with our next, Dr. Rukhsar.
Yes, ma'am.
Yeah. Do you have a presentation?
Yes, ma'am. No, ma'am, I don't have any slides.
Okay, then start.
Good afternoon. Good afternoon, respected hosts, the experts, and the participants of the contest. I am Dr. Rukhsar, a second-year postgraduate student. The topic for the presentation is back to what? Ethics, an unfinished agenda. We all speak about ethics, the moral values, and the morality. But do we follow the ethical principles? This is a point to ponder upon. Where do we learn ethics from? We learn ethics from our parents, our teachers, our colleagues, and the major part of it comes from within. So let's see what is ethics. Ethics is the philosophical phenomena of the moral values. It also called as the moral philosophy. It asks the investigates about the normative questions as to about what people ought to do or
Dr. Rukhsar. Dr. Rukhsar, if you can hear me, try turning off your camera. That might help with your speed. We seem to have lost Dr. Rukhsar. Are you there? Do one thing. Yeah. If you want, if you don't have good enough speed, turn off your camera and just speak.
okay, I'll continue, ma'am. Next is the
Okay.
loyalty. What is
Yeah.
loyalty? Loyal is not cheating is loyalty. Just be loyal and don't cheat with anywhere, with everyone. Just be loyal. Next is punctuality. Be on time or before time at your formal places like schools, business meetings, office meetings, etc. Just be on time or before time. Regularity. Be regular and have less day offs. For example, if you're attending one day of your school or college and making 4 to 5 days leave, jokes are bad, right? Just don't do that. Next is the regularity. Discipline. Maintain discipline in both your personal and professional life with what and how you behave and how you dress up. Next is the courtesy. Courtesy is being polite with pleasant behavior. It gives respect to others. Politeness is use your voice properly with soft, kind, and gentle tone, and while speaking to your parents, teachers, elders. Next, as a dentist, I'll highlight some of the points on the dental ethics as well. Dental ethics is the rights and duties and the obligations of the dentist towards the patients, the professional colleagues, and towards the society. It focuses primarily on the individual's rights rather than individuals as part of the society. It builds up the autonomy, self-determination, and protects the vulnerable and promotes the welfare and equality of the human beings. There are some of the dental ethical principles in dentistry. First is to do no harm, don't do any harm to the patient, which is the foundation of the for social morality. Next is to do good, that is the beneficence. Patient expect that with the the healthcare provider will initiate some beneficial action to the patient. So if like, for example, we hear a common saying, if you can't do any good, just don't do bad as well. If you can't treat any case, just refer it. It is also good. But giving an attempt is also right, but not always. Next is the veracity or truthfulness. The doctor-patient relationship is based on the trust. If you like, it threatens the relationship of the doctor-patient, and it next is the justice. Justice is giving the patient his or her right in the clinic. Then, like for allowing the patients in a queue in a dental clinic so that the latecomer should not go first. So you can always consider for the emergency cases. And autonomy in the informed consent. Autonomy is the giving the patient his or her right for the for the choice of this treatment. An informed consent is a written form of the willingness of the patient in the written form. It helps the dentist in the medical legal cases. So concluding with follow the ethics. Each letter in the ethics has its own meaning. E stands to evaluate the fact. T, think about the conflict presented. H, how many principles apply. I, identify the applicable codes and code sections. C, compare the different options and select the best option under any circumstance. So famous philosopher, American writer and famous philosopher says that Aldo Leopold, ethical behavior is doing the right thing when no one else is watching, and even when doing the wrong thing is legal. So thank you. I wholeheartedly thank the Oral Path 360 for providing me this opportunity. Thank you.
Thank you so much, Dr. Rukhsar. That was interesting. Our next presentation is Miss Azmi.
Hello.
Yes, you can share. Do you have a screen to share? Yeah.
Yes, I have a screen to share.
Okay, start.
Just a second. Good afternoon, everyone. I'm Azmi Peshimam. I'm from the Dental College, MIDSR Dental College, Latur. And today I'll be presenting the topic periapical lesions, which are a case of mistaken identity. Today we'll be looking at the periapical lesions, the histopathological findings, briefing of lesions that mimic periapical lesions, and the conclusion. As we are aware, periapical lesions are lesions pertaining to tissues around the apex of the tooth, the periodontal ligaments, and the alveoli. Periapical lesions are often misdiagnosed or often diagnosed on the basis of clinical and radiographical findings, which are different from histological findings, taking up a mistaken identity. Histological findings, the gold standard. Periapical lesions often present differently on radiograph, resulting in dilemma in the mind of dentists to come at a final diagnosis. Tissue from apices of non-vital teeth on examination microscopically represent periapical granulomas, cysts, infections, benign and locally aggressive malignancies. Since histopathological examination is the gold standard for establishing among various periapical pathosis, with emphasis on case showing unusual findings. Now we are going to have a look on some of the lesions which mimic the periapical lesions, starting with the first cyst, OKC or orthokeratosis. It arises from the dental lamina with microscopical findings that cystic lining of uniform layer of parakeratinized stratified squamous epithelium, which is 6 to 10 layers thick. The basal layer of cuboidal to columnar cells with hypochromatic and palisade nuclei, connective tissues containing epithelial islands or daughter cells. Radiograph consists of unilocular or multilocular, well-defined radiolucency with or without root resorption. The lesions has an aggressive behavior and high rate of recurrence. The second one is lateral periodontal cyst. It is one of developmental odontogenic cyst with dental lamina rest origin. The histopathologic evaluation cavity is lined by thin stratified squamous epithelium and in some area by focal nodular thickening. These lesions are asymptomatic and often can be misdiagnosed as lateral radicular cysts because of the similar radiographic features. The next common one is nasopalatine duct, which is asymptomatic. It shows pain and swelling of anterior palate. The histopathological examination shows cystic lesion lined by ciliated stratified squamous epithelium and fibrous connective tissue. In the way, it's similar in the radiographic view, which shows well-defined radiolucency in the maxillary mid-canine or apices. And this cyst can often be misdiagnosed as inflammatory periapical lesion when radiograph shows a superimposition on the incisor. The next common misdiagnosed lesion is central giant cell granuloma with the radiographic features of unilocular or multilocular radiolucency. The histologic examination consists of proliferating endothelial cells, fibroblasts, and myofibroblasts, small blood vessels, and multinucleated giant cells, often misdiagnosed as endodontic inflammatory lesion. Periapical cemental dysplasia is one of the other lesions which mimics lesions. These lesions like this are usually asymptomatic, showing multiple lesions but are often solitary also, showing in cellular mesenchymal tissue and collagen fibers with small blood vessels, mixture of woven or laminar bone and cementum particle. These lesions are similar to endodontic inflammatory lesions such as dental granuloma or radioplasty. Ossifying fibroma, which is a rare benign jaw neoplasm, which is constructed by connective tissue of variable cellularity with mineral component in form of tubercular or woven. And based on the amount of classified material, the radiographic view could be mixed or radiolucent and opaque. Malignant jaw lesions. Periapical lesions of non-endodontic origin might mimic lesions of endodontic origin. Several malignant lesions are observed in periapical areas such as lymphoma, leukemia, multiple myeloma, squamous cell carcinoma, chondrosarcoma. And insufficient knowledge about this lesion may lead to delay in prognosis. Infectious disease such as actinomycosis, histoplasmosis have been observed in periapical areas where the histopathologic examination demonstrates a band of fibrous connective tissue with chronic inflammatory cells and polyps. In conclusion, we come to the part that routine submission of periapical biopsies is required to establish a specific diagnosis anytime a recoverable amount of tissue can be removed from a periapical surgical site to rule out potentially destructive or life-threatening conditions. To avoid endodontic mistreatment, the dentist should know all odontogenic and non-odontogenic lesions that may present in the periapical area. Thank you, and I end my presentation here.
Yes, thank you. Periapical lesions are always among the most important for us dentists. So, going on to the next presentation, next is Miss Mansha Karki. Yeah, you have to turn on your mic, Mansha. Yeah, you can start.
Is my screen visible, ma'am?
Your screen share is
Good
not
afternoon,
visible.
everyone.
Your slides are not visible.
Is it visible now? Good afternoon,
No.
everyone. Myself.
It's still not seen. Okay.
Good afternoon, everyone. Myself Mansha Karki, and as white lesions in oral mucosa are commonly encountered in daily practices by our dentists, which are rarely symptomatic, but they have a 80 to 85% of malignant potential. Today, our presentation topic is diagnostic steps and interpretation of pre-malignant. Now, what do we actually mean by a pre-malignant disorder? A potentially malignant disorder is defined by WHO as a risk of malignancy being present in the lesion or condition either during the time of diagnosis or at a future date. So, how do we systematically approach these suspicious lesions? Generally, patients with such conditions are associated with tobacco medical history, in which its progression depends on the onset, frequency, and duration of the disease. Conditions generally come with symptoms of mouth sores, which does not heal, bleed spontaneously, which are velvety white, red in color, which are persistent mouth and very painful, due to which patient is unable to experience of
Mansha,
such
your
patients.
voice is breaking down. So just turn off your camera and only speak.
Okay, ma'am. After that, we clinically examine patients. We visually inspect the floor of mouth, tongue, or hard palate. We see for the color of the lesions, which can be white, red, or mixed in color, its texture, its gross appearance, and size of the lesion. After clinically examination, we do the diagnostic test. On the screen, as we can see, first is exfoliative cytology, in which only the substance as a sample. In brush biopsy, the complete transepithelial tissue thickness is removed. In tissue punch biopsy, a round sized tissue is removed as a sample. Alternatively, we can also clinically evaluate such lesions by doing salivary alterations in pre-malignancy or serum alteration. After doing clinical examination and diagnostic test, we would do the histopathological evaluation, which is of utmost importance. This lesion shows several stages of dysplasia. Features of dysplasia are increasing density of basal cell layer, increasing mitotic layer, increasing nucleocytoplasmic ratio, nuclear pleomorphism, and hyperchromatism. There are three stages of dysplasia: mild, moderate, and severe. The severe stage of dysplasia shows top to bottom dysplasia and is also called as carcinoma in situ. We have to keep in mind this stage has a high chance into transforming cancer. So here I would like to conclude my topic by saying it is very important for the patient and for the dentist to early diagnose such lesions to prevent a 360 change into malignancy. Thank you.
Yes, thank you for the presentation. And just reminding everybody that you need to vote at the link that is given on top of the chat, and also type in your name or any comment you want in the chat here. Besides voting, vote are required. Okay, our next speaker is Miss Deekshitha M.
Hello, ma'am. Is my screen visible?
Yeah, you need to go to presenter mode.
Okay.
Okay, you can start.
Okay. Hello, good afternoon, everyone. I am presenting about the research and trends of medical emergencies in dental office. Myself, Deekshitha. I'm an intern presently pursuing in Krishnadevaraya College of Dental Sciences, Bangalore. Now we'll look into the content. Diseases in younger adults, which will not be noticed. We'll look into it. Medical history negligence, preventive strategies, emergency management, emergency drugs, resurgence trends, and diseases harmful to the clinicians and patients. First, we'll go through arterial medical conditions to be noted in younger patients. Type 1 diabetes mellitus, which is also called as insulin-dependent diabetes mellitus, which is commonly seen in younger adults and will not be noticed during recording case history. And similarly, type 2 diabetes. Type 2 diabetes is also known as non-insulin-dependent diabetes mellitus. Anaphylaxis, it is adverse drug reaction, asthma, breathing problem, epileptic seizures, shock, syncope, temporary loss of consciousness, HPA axis suppression, hypothalamus pituitary adrenal axis suppression, which will reduce the cortisol production, and hence the person cannot tolerate the excessive stress and will be under the steroids. Next, hormonal imbalance, which is commonly seen in younger women adults. Next, birth control pills nowadays, which is commonly being used. And about these medical conditions, one of my friend is already explained. So we'll go into it. What are the causes for negligence of case history in young adults? A medical history is missed out in young adults because we see that it is mostly found in younger, not in younger age, only seen in later stage of life. Hence we miss it. Medical history plays a crucial role in clinical practice because the negligence may lead to unexpected complications with patients having medical conditions. So we have to stick to the standard protocol irrespective of any age. Prevention strategies. Taking proper health history. Recording proper health history, whether it is an older adult or younger adult. Regular checkup. Regular checkup helps in gaining the knowledge from the patient about his health history and health records. Standard practice protocol, investigations on health reports. If the patient is under some medical conditions, first investigate on his health reports before proceeding into any treatment plan. Next, discussing the issue with the co-doctor, physician consent, patient consent. Physician consent and patient consent plays a major role in treating medically compromised patients. Family awareness, which is again very important, quality practice, and emergency kit. Emergency kit should be available in all the private and government practices. How to emergency management. A quick recognition of signs and symptoms, early diagnosis, fast response time. The main important thing is PABCD. P for positioning, A for airway, B for breathing, C for circulation, and D for definitive care. The emergency drugs used in emergency management. Atropine used in bradycardia, aspirin, which is a blood thinner, epinephrine, which is an emergency drug, glucagon, nitroglycerin, ammonia inhalant buds. Ammonia inhalant buds are very much useful during the syncope, where temporary loss of consciousness happens. We give the patient to smell ammonia so that he'll come back to consciousness. Diazepam, lidocaine, naloxone hydrochloride are some of the emergency drugs I have mentioned here. Next, we'll look about the future trends in emergency management. As we all know, nowadays artificial intelligence is taking out the world. So there is an example in a US-based company. The AI completes the world's first automated dental procedure on a human. This is one example which I have put in the picture. Next is cloud computing, where the system server stores the information of the patient so that it will not be very difficult to go and analyze the things. Next is machine learning. Next, we'll come into the important thing, diseases harmful to doctors as well as patients. When this is a cycle, I have mentioned it here in a triangle, patient, doctor, and patient. This disease can spread to doctor to patient, or patient to doctor, or patient to patient. It is a two-way communication disease. So it is through contact transmission or any bloodborne diseases. In the bloodborne diseases, some examples are HIV, hepatitis B and C, measles. I would like to conclude this. Following standard protocol before proceeding treatment, well prepared, well acted. This means if we are well prepared before the treatment procedures, we are known into the medical history, then the treatment planning will be actually good without causing any emergency condition to the patient. Next, upgrading medical emergency kit. This is very, very important aspect for the clinicians, as they have to keep rechecking for the emergency kit and look for the expiry of the drugs so that they can replace earlier and doesn't damage to any one of them. Thank you. But I would like to say my inspiration from where I could choose the topic. One rare incident happened in one of the dental college where 24-year
Sorry, I
patient...
have to interrupt you. It's well beyond your time.
Okay, thank you, ma'am.
Yeah. Okay, our next presentation is Aastha Jakhar. Do you have a presentation to share? Miss Aastha, we can't hear you. We can't hear you. Have you tested this before? Click on the audio and see which microphone is selected. If the right microphone is selected.
Hello?
Yeah, now I can hear you.
Okay. Hello, everyone. My name is Aastha Jakhar. I hope you all are doing great. I'm from RHS College of Dental Sciences, Jaipur. So my topic is myofascial pain dysfunction syndrome. So what is myofascial pain and dysfunction syndrome? So myofascial pain and dysfunction syndrome, it is made up of two words, the myofascial. Myo means the muscle and the facial means the fascia. So it is a pain of the muscle and there is an inflammation of the underlying connective tissue. So it can be defined as a regional myogenic painful condition characterized by local areas of firm, hypersensitive bands of muscle tissues, often called as the trigger points. It can also be called as the myofascial trigger point pain. So it is mainly caused due to the hypercontraction of the elevator muscle. So there could be hypercontraction of one or more elevator muscle that can cause severe pain, tenderness, limitation of the jaw movements, and even there could be certain problems in PMJ. So next we have the mechanism. So we can have various types of etiological factors like the micro and macro factors like severe bruxism. Then we have the stress, anxiety that can cause certain mucoskeletal changes leading to muscle pain. Along with it, it can cause the hypercontraction of the muscle leading to muscle fatigue, accumulation of the metabolic byproducts that can lower the pain threshold and ultimately stimulating certain chemical and mechanical mediators that can cause MPDS. Now, MTRPs, that is myofascial trigger points, they are the big mischief in causing the MPDS. So it can be of two types, the active MTRPs and the latent MTRPs. Active MTRPs, they can be seen or they can be palpated easily on a muscle band, and they are also called as the jump sign. And the latent MTRP, they appear as nodular. The pain from these MTRP, they can radiate to maxillary, mandibular teeth, tongue, alveolar ridges, palate, frontal and temporal regions, pharynx, TMJ, and even on the occiput, ear, and the lateral surface of mandible. Etiology could be the severe bruxism, malocclusion, anxiety, stress, clenching of jaws, and increased sensitivity to pain. So there is a cycle that shows how myofascial pain dysfunction is caused by stress, dental irritation.
Aastha, we have lost you again. Aastha, are you there? I seem to have lost Aastha, and Aastha, are you there? Okay, let's go on with the next presentation. We will come back to Aastha later. Dr. Sakshi Arora, are you there? Yeah.
Yes, ma'am.
Okay. Are you sharing your presentation?
Yes, ma'am.
Okay.
Good afternoon, everyone. Myself, Dr. Sakshi. Today, I am presenting my thoughts on the topic compassionate communication, breaking bad news, and psychological
Dr.
treatment
Sakshi, you
strategies for the
haven't
cancer
gone to
patients.
presentation mode. Go to presentation mode.
Hello, everyone. Today, my presentation topic is compassionate communication, breaking bad news, and psychological treatment strategies for the cancer patient. Being a doctor, we have spent years studying, training, practicing for the long hours, just with an aim to save the patient's life and to give them a better future. We are well trained to diagnose and treat the disease. Let us once keep that all aside and imagine telling your patient who have placed their trust in you and telling them a news that will completely change their life forever, telling them that they have a cancer. Can you imagine how life will be after hearing that? It is such a very sensitive topic, yet no one talks about it. So, what is bad news? Any news that drastically and negatively alters the patient's view of her or his future. A bad news is always a bad news, however well it is said, but the manner in which it is conveyed can have a profound effect on both the patient and the professional. So, first and foremost, we should always remember that when we deliver a bad news, we are not merely communicating a diagnosis, but we are entering their world, the world that is suddenly feeling like a crushing. So breaking bad news is very sensitive, complex, but important communication skill that we all should know. So the main cause that we are lacking is because of our skills and our reluctance to deal with the patient's feeling. So we should always show some empathy or sympathy with the patient. So to deal with that breaking bad news, there is one protocol called Spikes protocol. The where S stands for the setting, means we give a privacy to the patient, being make them comfortable, a non-threatening setting, and P stands for the perception, uncover, what patient family think what is happening here. We tell about the disease invitation. We ask the patient to because they ask us the questions that he wants to know about, and the knowledge K means knowledge. We explain the disease and the case options in their normal language. And E is matlab emotion, that is respect, feeling, respond with the empathy. S means summarize, means recap and decide what next in the future. So after that spikes protocol, or after communicating, or after breaking the bad news, we must remember that this conversation is not the end of our relationship with the patient. It is just a beginning. So as a patient and family members constantly needs a psychological help to deal with such an event. So before, during, and even after the treatment of the cancer, patients need psychological treatment. We always think of the cancer treatment like the surgeries, the chemotherapy, the radiation, but we never think about the battle that is going inside the mind of the patient and the family members. So it is not very uncommon for the patient to experience during that phase of the fear, anger, and the sadness. Also, that leads to the anxiety disorders, the depression, or even the post-traumatic stress. So we should always provide a safe space where patient can express themselves or feel, because the feelings are crucial. Also, we can help them by providing the counseling and the therapy so that patient can learn to process their emotions and regain a sense of control. Also, after the patient, the family members, the person that provide the care and support to the patient also need the therapy or the counseling. We should offer the psychological support to the families also to ensure that they too have the resources they need to cope, to support their loved ones, and to maintain their own well-being. So our objective as a healthcare professional should be, we should always know some perspective on the oral cancer, or the how it is going to be for the treatment purpose. And we should always practice in relation to the breaking the bad news to the patient. Also, we should have some training on the spikes protocol, how to break the bad news. Also, to give some psychological treatment to the cancer patients. So I'm concluding my presentation with a quote by the Buckman, a psychologist, who said that breaking bad news is if we do it badly, the patients or family members may never forgive us. But if we do it well, they may never forget us. So in conclusion, psychological treatment is not a luxury in the cancer care. It is a necessity. By addressing the emotional, existential, and the social challenges of the cancer, we can help patients not only survive, but live fully even in the face of illness. Thank you, everyone.
Yes. Thank you, Dr. Sakshi. In case you want to hear such lectures, you should check out our channel because we actually have lectures on such topics.
Okay, ma'am.
Yeah. Okay, next. Now we are going to the second group that is in the poll where you are voting. You will find these as the second lot of names. So our next presenter is Vasanthan M. Is Vasanthan here?
My screen is visible.
Yes, it's visible.
Good afternoon to all. I am second year student of Nanda Dental College, and I am going to present here a topic of pemphigus vulgaris. These are the content which I am going to present here. First, we want to know what is pemphigus vulgaris and how it is caused, and what is their pathogenesis, and how it is clinically presented. These are the four major types of pemphigus. First one is pemphigus vulgaris. This lesion can be present in both cutaneous and mucous membrane. And pemphigus foliaceus, it can be present only in skin. And another two rare are drug-induced pemphigus and IgA-mediated pemphigus. First, we want to know what is pemphigus. It is a type of autoimmune disorder leads to blister formation in both skin and mucous membrane. And it is due to when there is a loss of adhesion between the epithelial cells. How it is caused? It is one of the most important genetic factors. Actually, gene. It is a genetic marker of this pemphigus vulgaris. And such environmental factors such as UV radiation and other toxic chemicals can also lead to this autoimmune condition. And some hormonal fluctuations in females during pregnancy or menopause can also cause this autoimmune disorder. And it is the most rare autoimmune disorder which can affect only 1 to 3% in 1 lakh population. In that, females are more prone to that. And these are the various theories which will propose in pathogenesis of the pemphigus vulgaris. But the most common pathogenesis is there is a development of autoantibody that is directed against an adjacent molecule called desmoglein 1 and 3. And this will lead to there is a breakdown of the adjacent between the epithelial cells, and it will lead to an inflammatory reaction and leads to blister formation. When the autoantibody is directed against only desmoglein 3, it will present only in mucous lesion. When it is directed against both desmoglein 1 and 3, it will be appear as in both cutaneous and mucous lesion. And mostly older age groups are get affected in that oral lesions are the first indication of this autoimmune disorder. And these lesions are ruptured easily and form a painful and hemorrhagic erosion. Yearly lesions are filled with watery fluid, and Nikolsky sign is an important clinical feature which we have to do. Nikolsky sign when we apply pressure on the blister, the blister will break down and there will be a separation of upper epidermis from the basal layer. This indicates then this type of autoimmune disorder. And in that Nikolsky sign, when you apply mild pressure to the blister, there will be a spread of blister to the unaffected side. It is also another indication for this autoimmune disorder. And the most important diagnostic tool is one is ELISA to detect an antigen, and that immunofluorescence is to detect an antibody. And these are the histological image. There will be seen an intraepithelial separation between the cells and spongiosis. Spongiosis means it is in skin inflammation due to accumulation of the fluid, and acantholysis of keratinocytes. Acantholysis means there is a loss of coherence between the epithelial cells and the Zang cells. Zang cells are the multi-lobed giant cells. This formed due to an acantholysis. This Zang cells are not only seen in pemphigus vulgaris, it is also seen in the herpes infection and some of the inflammatory cells. And there is a tombstone appearance of cell can be visible. Tombstone appearance is due to only basal cells are attached to the basement membrane, so it will appear as a tombstone. While doing in direct immunofluorescence, we can appreciate there is an IgG mediated IgG antibody and complement 3 proteins are deposited between the epithelial cells. And these are the histological image. Here we can appreciate a tombstone appearance of the cell, and this is called Zang cell. And biopsy. Biopsy should be taken only in the perilesional site, should not be taken directly into the lesion, because we only get a non-specific and reactive type of inflammation only we can observe. Next, treatment. Treatment for the oral lesions is we can give an topical corticosteroids like dapsone or tetracycline gel can be given. Our skin lesion, if it is in skin lesion, we administer systemic corticosteroid at initial dose of 40 to 60 mg, and first is in dapsone and azathioprine and cyclophosphamide. We should carefully monitor a patient who is undergoing systemic corticosteroids because they can develop a side effect like bone marrow suppression and anemia and certain malignancies and hepatic toxicity. These are my references. And thank you to.
Yes, thank you for that presentation on pemphigus. Yeah, Aastha, I guess you have joined us again. We will keep your presentation for the end now. We will go through it again. So our next presentation is Dr. Shanmuha Priya. Dr. Shanmuha, you're here? Dr. Shanmuha is not there, then we will go on with Kriti Agarwal. Yes. Yes, Kirti.
Thanks for the opportunity, ma'am. Hello, everyone. This is Dr. Kriti Agarwal. I am a second-year resident. As a second-year resident in the field of oral pathology, it's always a question of concern that what is the future in oral pathology. So my topic is with this regarding the advancing oral pathology, current insights and future directions. Imagine a future where a simple saliva test can predict your risk of oral cancer, or where AI can diagnose complex oral diseases within seconds. This is not a science fiction, but this is an exciting reality shaping the future of oral path. Today, we will dive into the most intriguing developments in oral path and explore what the future holds for this vital field. So currently, in diagnostic techniques, molecular diagnostic techniques like polymerase chain reaction, that is PCR, FISH FISH, that is fluorescence in situ hybridization, next generation sequencing, that is NGS, allows a deeper understanding of molecular pathways. Moreover, in the current situation, the biomarker contributes to the early detection and monitoring of diseases such as oral cancer, and other innovation is in the field of stem cell research. Stem cell research which promote the treatment of oral diseases by tissue regeneration and functional restoration of that particular site. So they also help in personalized treatment strategies for that particular lesion. Now, the most upcoming field is of AI. We know that integration of artificial intelligence and machine learning can improve the efficiency of diagnosis, risk assessment, and treatment planning. Moreover, telepathology, that is the different scenario of digital pathology, will facilitate the remote consultation, which is not available if we are doing at the same place. So telepathology will facilitate the remote consultation and second opinions we can also take in that. This platform will allow pathologists to share and collaborate the various cases. So this will be beneficial for the areas in which there is a limited access of specialists, that is oral pathology services. Next is future direction in researches. The future perspective of oral path hold promising developments and innovation that are likely to share in the field in recent areas, like continued research in identification of specific biomarker associated with oral diseases will lead to more accurate and early diagnosis. The AI, that is AI is now applicable, but in the future there is more wide area in the field of AI. So integration of AI algorithm can process large data set, analyze complex patterns, and assist in interpretation of various diagnostic images. We can send it by apps, or we can use the digital pathology application to send it to some other area where we can take the second opinion with other specialists, and in the areas where specialists are not available. Next is contribution of oncologists, geneticists, and other specialists will provide better understanding of oral diseases, which will contribute to more comprehensive care of patient. In upcoming time, regenerative medicine, tissue engineering will offer the regenerative solution for damaged and lost tissue. In the upcoming time, it is very important to regenerate or reconstruct the part after the surgical operation has taken place. So the regenerative medicine will play the important role in that. Other thing is that the academic and research landscape in oral pathology will expand with the surge in publication and researchers activity. This can be expanded in the future by national, international, and collaboration of different authors, which can be done intercity and in international collaboration. At the end, I only want to emphasize that there is always the possibility to expand, see the opportunity and grab it. Here we can see in this diagram the current insight in the field and the future frontiers. So there is always the expansion in this field also. So see the opportunity and grab it. Thank you.
Yes, thank you. There definitely is always a lot of opportunities when one goes looking for it. Okay, our next presentation is Monika Sharma. Monika, are you there? Right. If Monika is not there, the next is Gauri Deshmukh. Is Gauri Deshmukh?
Yes, ma'am.
You're there. Okay. You got to turn on your camera.
Yes, ma'am.
Okay. Yes, you can start, please.
Yes, ma'am. Just a minute. Yes, ma'am. Ma'am?
Yeah, it can be seen. Yeah, it is seen. Start.
Okay. Good evening, everyone. Myself, Dr. Gauri Deshmukh. I'm a first year PG student from MGV's KBH Dental College. And today's my topic is the Vivascope. Globally, oral cancer ranks sixth among all types of cancer since last few decades. India is becoming the hub for oral cancers. Oral cancer poses a serious health challenge to the nations undergoing economic transition. As compared to the West, the concern of oral cancer is significantly higher in India, as about 70% of the cases are reported in the advanced stages. Early detection and precise removal of the oral squamous cell carcinoma is essential for optimal therapy and prognosis of the patients. Confocal microscopy is a technique for real-time visualization of the tissue with very high correspondence with conventional histopathology. Vivascope is the device which uses confocal microscopy technology for imaging the tissues. The introduction of oral probe with a very high sensitivity and specificity in the diagnosis of OSCC have been reported. Its use has been reported for the first time in Asia for the diagnosis of gastrointestinal pathology. It can be of two types, either in vivo or ex vivo. In the in vivo, it is directly applied to the skin, and ex vivo, it is applied to the excised but unfixed tissue. A Vivascope ex vivo confocal microscopy is an innovative device that allows rapid real-time microscopic examination of the excised tissue within a few minutes without traditional tissue processing. This device basically has a three modes: reflectance, fluorescence, and the pseudocolor. In the reflectance mode, no staining is required because the contrast is based on different refractive index of the cellular structures. The fluorescence mode uses the different colors for different tissues. Pseudocolor mode appears same as that of H&E. This is the procedure for the microscopy. The procedure involves immersion of the sample in the acetic acid followed by staining with 0.6 millimolars acridine orange. The excised tissue is flattened between the two sponges held in place by magnetic slides for stability during scanning. The time required to scan the tissue of around 8 by 8 millimeters is 50 seconds. Of course, it depends on the size of tissue also. These are the photomicrographs, so pseudo-colored images of vivoscopes mimicking the traditional H&E and images of the confocal microscopy. Presently, vivoscopy is being used as an adjunct diagnostic modality in many clinical practices and research settings such as skin pathology, uropathology, gastrointestinal pathology, and gynecopathology. It has also been applied to the diseases of oral mucosa, but very few studies have been reported so far in the literature. Vivoscope has a proven application in detecting mucocutaneous pathologies, infections, and its uses in the oral premalignant diseases, and oral squamous cell carcinoma is being researched extensively. Here are some advantages. It's a non-invasive real-time tool that enables the visualization of the tissue structure, providing a bedside examination at a cellular level and guiding the biopsy if necessary. Ease of intraoperative transportation with the efficient sample processing. Vivoscope reduces the procedure time by approximately 1/3 and reduces histotechnician time spent on the frozen section and hence reducing the operating cost also. It increases opportunities for the telepathology and teaching as images can be electronically protected and shared without need to send the physical slides. As every coin has a other side also, it has some limitations. It requires training and experience to obtain the adequate histopathological imaging. Inability to flatten the tissue can obscure adequate evaluation of the entire specimen, resulting in a false negative results. And of course, the third and the most important thing is costs. It costs around 3,000 US dollars. Here I conclude, my concluding sentences will be, why Vivoscope is a revolutionary tool that can be used as an adjunct to paraffin fixed HNE stained histological slides and frozen sectioning. Vivoscope has shown promising results in the diagnosis of skin lesion, GI tract pathology, having the way for use in early diagnosis of oral lesions also. And I conclude my presentation with some of the references. Thank you.
Thank you for that presentation. It's a very interesting tool. Our next presenter is Dr. Devika Boppidi. Are you there?
Yes, ma'am.
Okay.
Ma'am, is it visible?
Not yet. It is saying sharing. Yeah, now it is visible, but your own camera is off.
Yes, ma'am. There is some problem with the camera.
Okay, fine. Now you can start.
Good afternoon, everyone. Myself, Dr. Devika, intern from Krishnadevaraya College of Dental Sciences and Hospital, Bangalore. The sizzling spices flavored quid, a silent saga of oral submucous fibrosis. Oral submucous fibrosis, it's a potentially malignant disorder. It's chronic, insidious, characterized by juxtaepithelial hyalinization and loss of fibroelasticity. So talking about the etiology, there are some local factors as well as some systemic factors. Local factors include quid, chilies, mostly aracanid, and when coming in contact with the lime and tobacco chewing habit. And systemic factors include nutritional deficiencies, genetic predisposition, and autoimmunity. So why India? The incidence is 4.47 in world and 6.36% alone in India because of the etiological factors. That is quid, chilies, aracanut, which is in the major use in South Asian countries. With a male predilection, and the risk of conversion into malignancy is about 6%. Pathophysiology. The components of arachanids include the alkaloids, flavonoids, and fibroblasts, which in turn production of collagen is increased. Flavonoids increase the cross-linkage of the formed collagen fibers, and they're also resistant to the collagenase enzyme. Copper also stimulates the fibrinogenesis. The first case is about the oral submucous fibrosis seen in a 41-year female patient who complained about difficulty in mouth opening since 6 months. She also gave a history of burning sensation, and the mouth opening is restricted to less than 15 mm, which shows a 4th stage of OSMF. The etiology included arecanut and betel leaf, along with tobacco since 20 years. The histopathology revealed the atrophied epithelium, subepithelial hyalinization with involvement of submucosa. We see the same case in mostly 60 to 80%, but do we think all the cases are similar? I don't think so. I would justify this with my another case presentation. A 62-year male patient who complained of restricted mouth opening with ulceration seen in his left buccal mucosa. The histopathological changes included the dysplastic epithelium invading into the connective tissue. And in the molecular level, I would like to talk about these 3 factors. NF-κB, it's a transcription factor that promotes tumor invasion, migration, metastasis, and angiogenesis. The STAT3, which increases the secretion of major inflammatory cytokines, leads to uncontrolled growth and malignant transformation. And then the HI1 alpha activates the transcription of tumor invasion related genes. Coming to the treatment for conventional OSMF without any malignancy, the following could help out, which give the symptomatic relief, decrease the fibroblastic proliferation, has anti-inflammatory properties. And when the OSMF is along with the oral squamous cell carcinoma, the treatment protocol is same as we do for oral squamous cell carcinoma. That is the excision of the tumor along with the adjuvants like chemotherapy and radiotherapy. Talking about the prognosis, whether it's the good or bad prognosis, I would like to mention about some of the prognostic factors that includes the location, thickness, the staging, grading of the tumor, and then presence of perineural spread, mandibular invasion, and lymph node invasions. I would say that the prognosis is bad because almost 51.2% overall survival rate is seen and 59.2% disease-specific survival rate is seen. But what changes can be made? As a dentist, we can create an awareness among the people before the malignancy when they're in the pre-malignant stage, either in the clinics, in the colleges, and also in the awareness where, especially in the farmers and when the security guards and people who are more used to it when in their free time. Thank you.
Thank you for that presentation. Yes, this is one of those diseases where the prevention totally lies with the youngsters and the next generation and everyone who is a dentist and in practicing dentist, basically. Now, next is C.P. Cladiya Prasanna. Are you there? Yeah, I can see you there. Okay.
Yes, ma'am.
Yeah, do you have a presentation?
No, ma'am.
Okay, I'm starting your time.
Yes. Good evening to one and all present here. Myself, Cladia, a third-year BDS student of PMNM Dental College and Hospital. Today, I'm going to speak a few lines about osteomyelitis. Osteomyelitis is defined as an inflammatory condition of the bone that begins as an infection of Haversian system, rapidly extends to the medullary cavity, rapidly extends to the Haversian system, and involves the periosteum of the area. Osteomyelitis can be classified as suppurative and non-suppurative. In suppurative, we have acute, chronic, and infantile. In non-suppurative, we have focal, diffuse, periostitis, proliferative periostitis, and osteoradionecrosis. It can also be classified as specific and non-specific for actinomycotic osteomyelitis and tubercular osteomyelitis. Now let's see the predisposing factors for osteomyelitis. Its low risk of incidence is largely because of the host resistance. Osteomyelitis affects patients with hereditary conditions such as uncontrolled diabetes, leukemia, syphilis, cancer chemotherapy, and acquired immunodeficiency syndrome. Conditions that alter the vascularity of the bone will predispose for the onset of osteomyelitis. Example, osteopetrosis, radiations, etc. Let's look into the etiology of osteomyelitis. Osteomyelitis is initiated as a foci of infection or trauma. Osteomyelitis is usually involves the mandible and it is less seen in the maxilla because maxilla has wide and extensive vascular supply. Osteomyelitis begins as an acute inflammation which leads to pus accumulation. This accumulation of pus causes an increase in the intramedullary pressure, which in turn will cause vascular collapse, stasis, ischemia, leading to avascular bone formation. Microbiology. Osteomyelitis was initially believed to be caused by Staphylococcus aureus and Staphylococcus epidermidis, which ranges about 80% to 90%. Now, the recent studies have told that the primary organism responsible for causing osteomyelitis is Streptococcus and other oral anaerobes such as Peptostreptococcus and Fusobacterium. Clinical findings. Clinical findings of osteomyelitis varies for different types. In case of acute suppurative osteomyelitis, we can see high intermittent fever, deep intense pain, paresthesia of the lower lip and cheek, and caries with respect to the involved tooth. Radiographic. Osteomyelitis can be diagnosed by conventional radiographs, CT, MRI, and radio bone nucleotide technology. The bone has a moth-eaten appearance. The new bone is called as involucrum and the dead bone is called as sequestrum. There appears a zone of radiolucency separating the sheath of involucrum from the sequestrum. Diagnosis. Careful correlation of case history, physical examination, and radiographs is necessary to distinguish osteomyelitis, and it is also helpful in the diagnosis of osteomyelitis. And complete declination of the contour surface will help us to differentiate between the other bone tumors from osteomyelitis. Treatment. Treatment will differ depending upon the different types of osteomyelitis and the extent of involvement. The basic principles of treatment of osteomyelitis include evaluation and correction of host defense deficiencies, gram staining, culture, and sensitivity, bone scannings to rule out the bone tumors, imaging, administration of stain-guided antibiotics, removal of loose teeth and sequestrum, administration of empirical guided antibiotics, then possible placement of irrigating drains or polymethyl methacrylate antibiotics, sequestromy, debridement, decortication, resection, and reconstruction of the bone. Thank you.
Thank you for that presentation. Now, next we have Miss Ayesha Haanee Ali. Are you there? Miss Ayesha? The presenter after that is Parul Mehta. Parul Mehta there? Right. What about Miss Neha Choudhary?
Good afternoon, ma'am. Yes, I'm here, ma'am.
Who is here? Neha is there. Okay. All right.
Begin, ma'am.
Yes, you can begin.
Am I audible and visible?
Yes, you are audible and visible.
Good afternoon, one and all present here. This is Dr. Neha Choudhary, first year PGT, and the topic of my presentation is lichen planus, deceptively simple. The reason I chose this topic is that as a third year undergraduate student, when I was introduced to this beautiful world of oral pathology, I tend to believe that lichen planus is all about the P's, like purple, polygonal, papule, pruritus, also along with some Wickham's striae and stress. But is it as simple as it sounds, or the common notion of mankind that looks are deceptive applies here as well? Given the wide array of presentations, apart from the so-called characteristic feature, this lesion is a true master of disguise. I have come to believe that this lesion is deceptively simple, and therefore I want to utilize this wonderful platform to present a self-written poem on my understanding of this lesion. So here I begin. Appearances can be deceptive. It's true. I learned that from a disease I thought I knew. T-cell mediated autoimmune disease is what I have been called. The idea of Greenspan syndrome also has been stalled. Dermatologists know me by the 6 Ps, bilateral and symmetrical, but often this idea is usually a whimsical. Sometimes I hide in the anterior part of the eye, looking exactly like conjunctivitis. Rarely, I could be just a hyperpigmented lesion on the skin with no pruritus. I can mask behind dysphagia and GRD. In that, then I am called lichen planus esophagitis. I'm a wonder in true sense. For I could be atrophic, hypertrophic, vasculobullous, actinic, or classically a papule, which can be dense. Dentists know me as a pre-malignant lesion. For students, they say I arise during the exam season, but just dental trauma or stress are not always the reason. In the oral cavity, I'm in reticula pattern, something like a lace. But is that always the case? Contrary to a journal norm, I could also be in erythematous or erosive form. I could be troublesome, causing periods of relapse and remission, especially when linked to hepatitis C and malnutrition. Diagnosing me is not as simple as it sounds, as I can take up many grounds. When on gingiva, it is the vasculobullous lesion I mimic, but there you can recognize me using the direct immunofluorescence gimmick. Under the microscope, I am known to have retipex resembling a sawtooth, but that certainly does not mean that my retipex cannot be smooth. There is a band-like subepithelial mononuclear infiltration along with basal cell liquefactor degeneration. Sometimes I have a Max Joseph space, but some people call it an artifact case. Treating me can burn a hole in your pocket, as steroids, retinoids, for dynamic therapy can be used to block it. I am not just limited to 6 Ps on this trial, you know. I am more than what I show. Appearances can be deceptive, it's true. I learned that from a disease I thought I knew. Thank you.
Thank you. That was very interesting. And in the true spirit of an open mic, I must say. Yes. Okay, so just before now, we are ready to go for our break. But before that, let me ask if any of those who missed are here with us now. That would be Dr. Shanmuha Priya or Miss Monika Sharma, Ayesha Haanee Ali, or Parul Mehta. Okay, Ayesha, you're there? Okay, you want to make your presentation, please? You can share. Right. Okay, starting your time.
Okay. Hello, everyone. I'm Ayesha Haanee Ali, third year dental student at JSS Dental College and Hospital. I'll be presenting Jain cell fibroma at today's contest, where I'll be discussing what Jain cell fibroma is, the clinical features, histopathological features, differential diagnosis. I'll also discuss 2 cases seen at a hospital and the treatment of GCF. So it was described by Weather and Callahan in 1974. Now, what is Jain cell fibroma? It is a non-neoplastic lesion that mimics other fibroepithelial lesions clinically. However, it is identified as a separate entity due to its different histopathological findings. And how is it different from fibroma? It's the distinctive histopathological features that sets it apart from the conventional fibroma. Coming to the clinical features, it appears as an asymptomatic sessile or pedunculated nodule that is less than 1 centimeter in diameter, often having a bosselated or papillary surface. It is commonly seen in females with the age group of 10 to 30 years, and common sites of presentation are mandibular gingiva compared to maxillary gingiva, also seen in palate and tongue. Differential diagnosis of GCF is squamous cell papilloma, irritation fibroma, pyogenic granuloma, as well as peripheral Jain cell fibroma. Now, I'd like to discuss 2 cases seen at a hospital. Here's the first case where a 25-year-old female patient visited the hospital with the complaint of swelling in the upper left back tooth region since 2 to 3 months. The swelling was initially small, then grew up to the present size. On intraoral examination, a diffuse irregular swelling measuring about 5 into 4 centimeter in size, distal to 2.8, extending into the hard palate was noted. A smooth surface, pale pink, firm swelling that was well demarcated from the surrounding tissue was seen. A similar case was seen where a 60-year-old female patient presented with a chief complaint of swelling in the hard palate with the size of about 1 centimeter in diameter. On intraoral examination, it was roughly oval in shape with irregular borders. Here are the gross specimens of both the swellings. Now, coming to the lesions were excised and sent for histopathological findings, and the provisional diagnosis of fibroma was given. Coming to the histopathological examination of hematoxylin and eosin stained sections of both the tissues from both the cases revealed hyalinized connective tissue showing moderate amount of large plump, spindle-shaped stellate fibroblasts. Some of these cells were multinucleated with dendritic processes, and these cells, as you can see, are present in the peripheral region of the area, whereas the central area contained more fusiform typical fibroblasts. And dense, deeper connective tissue were present with the presence of focal inflammatory cells around the blood vessels. Based on these features seen, a final diagnosis of Jain cell fibroma was given. And coming to the treatment, complete excision was performed in both the cases, and recurrence is rare in general. Thank you. Have a nice day.
Thank you for that presentation. Okay, now we have reached the midway. Although I must say the presentations have been interesting, so it's not really that we need to take a break, but I think we need to take a break to, give our eyes a break. So we will take a 5-minute break and we will be back. in the 5 minutes, I will play a video. So the sound is there. So you can get up and walk away, stretch, and you will know when to come back because the sound will stop. Right. So let me just share and then we shall be back in 5 minutes. Yes, our break is over. I hope you did get up and stretch and drink a glass of water just to refresh yourself. And now we are back. And going on to our third group, that is the third set in your in the voting form. And the next presenter is Kritika Mishra. Are you there?
Yes, ma'am, I'm there.
Okay.
I'll share the screen.
Okay.
Is it visible now?
Yeah, it is. I'm starting your time.
Okay. Good evening, everyone. I'm Dr. Kritika Mishra from Krishnadev Rai College of Dental Sciences and Hospital, Bangalore. Today, I'm going to talk about the hidden aggression of the variants of oral squamous cell carcinoma. Are they subtle or are we underestimating them? As we all know that OSCC is a prevailing lesion, malignant lesion, prevailing in India and South Asia, and majorly caused by tobacco chewing, areca nut chewing, chronic ulceration, radiation, and human papilloma virus. It is presented clinically in ulcerative, ulceroproliferative, and exophytic lesions and has many variants like verrucous oral squamous cell carcinoma, etc. Some low-grade variants have good prognosis, whereas some high-grade variants have poor prognosis. Today, I would like to take this opportunity and present a case that we came across. We see an extensive lesion measuring about 3 into 4 centimeter with one nodular growth and several sessile pinkish projections. A female patient with no habits, we can give differential diagnosis of several virus-related lesions like squamous papilloma, verruca vulgaris, condyloma acuminatum, Hicks disease, and non-viral lesions such as verrucous carcinoma. So for the investigation, we did a biopsy, and on grossing, we see an exophytic lesion. And when we cut it, we see an exophytic growth and an endophytic growth, which is supported by a thin connective tissue stroma. So under the microscope, we see multiple bulbous ridges, elephant foot processes, pushing margins, blunt papillary projections, and parakeratin plugging. On a further closer view, we see several dysplastic changes. We see acanthosis and numerous mitotic activities going on, increased nucleic cytoplasm ratio, and nuclear hyperchromasia. So, what is the diagnosis? Is it a giant verruca or a verrucous carcinoma? So what did we see in this case? An exophytic lesion with blunt papillary projection and thin connective tissue course, keratin in clefts, bulbous ridges, pushing borders, acanthosis, basal cell hyperplasia, juxtaepithelial inflammation. And along with that, we also see moderate to severe dysplastic features, including increased nuclear cytoplasm ratio, numerous mitotic figures, and nuclear hyperchromasia, and a few foci of acanthosis. In the histological slides, we see bulbous ridges, increased dysplastic changes, mitotic activities, and an epidermal histologic variant with basaloid pattern dysplasia in BLT. What is BLT? Buschke-Lowenstein tumor. Very rare tumor of the oral cavity, which is generally seen in the anogenital region and sometimes the oropharynx region. It is commonly associated with the second and third decade of life and associated with immunosuppressive state and human papilloma virus. So we did a PCR test for the high-risk HPV variants like 16, 18, etc., and low-risk human papilloma virus variants like 6, 11, 26, etc., but the test results were negative. So what conclusions did we arrive at? A 76-year-old geriatric patient with no habits, no medical history of diabetes or hypertension, with papillary or papillomatous extensive lesion, high mitotic rates, high-grade dysplasia, no keratin resistance on grossing, and negative for HPV, with a lesion that has a high rate of recurrence, about 50 to 60%, and which is locally aggressive. Keeping that in mind, we asked the patient to be in a regular follow-up, and in the last 2 follow-ups, we haven't seen any recurrence yet. So the treatment that we usually suggest during no dysplastic changes is wait and watch, When it's verrucous carcinoma, we go for a conventional treatment plan, that is surgical excision. But when we see a severe dysplastic change, we go for surgery as well as adjuvant therapy like chemotherapy or radiotherapy. When we see high mitotic rate, we go for targetoid therapy, in which we give drugs that will block the mitotic activities. So what messages do we take back with us? The oral squamous cell carcinoma has multiple variants and presentations, but the low-grade variants can be deceptive and they might not be as low-grade as we think. So we need to look for high-grade changes through histopathological diagnosis, and we have to be aware and we have to have the knowledge about the rare lesions, the different variants, and that is how we can be better at the prognosis, and we can tackle the aggression and we can tame the aggression. With that, I would conclude my presentation. Thank you so much.
Yes, thank you for your presentation. Our next
Thank you.
presenter, as I can see, is already here. Yes, Priyal? Yes. You have to turn on your mic.
Good evening, everyone. Myself, Priyal Rambhia from JSS Dental College, Mysore. Today, I'm going to speak about mask mouth, the dental dark side of mouth mask. As we all know, since the pandemic, mouth mask has become an essential part of our life, isn't it? It has become a companion in daily life to protect infections and airborne diseases. But have you wondered the mouth mask which protect us when worn for a longer period of time can cause adverse effects on health? Yes, it does. What is mask mouth? It's an entity named to indicate all the side effects that are produced in the oral cavity and related structures as a result of long-term wearing of the face mask. Now, let's explore about the causes of mask mouth. First, it causes irregular breathing pattern, and due to irregular breathing pattern, there is mouth breathing, and due to mouth breathing, there is reduction in salivary flow rate, and thus causes dryness in the mouth. This dryness in the mouth makes reduce buffering capacity, and which causes gives a platform for Streptococcus bacteria to grow in, and causing various oral diseases like gingivitis, halitosis, dental caries, candidiasis, and ulcers. Now, let's know about the signs and symptoms of mask mouth. It is dry mouth, halitosis, gingivitis, dental caries, candidiasis, angular cheilitis, ulcer, acne, perioral skin irritation, and infections. So, how do we prevent it? We all know prevention is better than cure. So, how do we do it? First thing is important is frequent rehydration. The thing is, when we put the mask, we forget sometimes to drink water. So, it's very important for us to drink water whenever we get the leisures. The second thing, wear a clean mask and make sure you wash your mask every day. The most important thing I want to tell you about is to maintain good oral hygiene. And how do you do that? Brush twice daily, use fluoridated toothpaste, use floss and alcohol-free mouthwashes. Then I want to tell you about how does a healthy gum come. When you have a balanced diet with a proper supplements of vitamins and minerals. Now I'm going to talk about the most crucial thing, that is you have to seek a regular oral checkup every time. Thank you.
Thank you for that interesting presentation. Our next presenter is Miss Vaishnavi Chitte. Yes, you're there.
Yes, ma'am.
Okay.
Can I start now?
Yeah, start.
Good evening, everyone. Myself, Vaishnavi Chitte, studying in 3rd BDS, MIDSR Dental College, Latur. Today, my topic is analysis of artificial intelligence in oral pathology.
So basically, artificial intelligence is a science that focuses on how machines can stimulate human cognitive functions to perform specific tasks, thereby reducing workload and work time. The clinical manifestation of oral diseases can often overlap, making the differential diagnosis a complex and challenging task for the oral healthcare professional, such as variability in symptoms, multifactorial etiology, similar lesion appearance, overlap with systemic disease diagnostic techniques. To address these challenges, there is a growing interest in digital technologies and AI in oral pathology, like improved diagnostic accuracy, individualized treatment planning, efficient workflow, education and training, research and development. Furthermore, by analyzing extensive data from patient medical records, AI involves techniques that provides computers to emulate human behavior, enabling them to learn, make decisions, recognize pattern, and solve complex problems in a manner akin to human intelligence for diagnosis, treatment, and prognosis. The role of artificial intelligence in oral cancer screening. There is an app named as Mobile Mouse Screening Anywhere. This app, which is used to capture images of the oral cavity for the remote interpretation by specialists for the tumor diagnosis, prognosis, clinical decision, and for tumor therapy. The current available techniques we are using are like vital staining, oral cytology, optical imaging, DNA methylation biomarker, protein biomarker. Then we can adapt new techniques like AI-based systems such as 3D photography, intraoral scans, lab-on-chip, DNA ploidy test, also called as DNA index test. When we talk about the mobile mouth screening app, it took place in 4 steps, which requires hardly 6 to 7 minutes. Step 1 is wide field imaging, cancer risk map projection, multimodal imaging, and last one is biopsy guidance map. Then how AI is helpful in healthcare for the early detection, improved decision making, virtual health assistant, treatment of rare diseases, and robot-assisted surgery. AI also used in dentistry when patients come visit to us clinic, then machine learning diagnosis done as per the requirement. We determine the treatment plan for prosthodontics, or patient should require the surgical treatments, endodontics, periodontics treatments. How AI reduce the burden from medical practitioners by rapid screening of construction strategies, cost-effective extraction of multi-scale image features, streamlined analysis of multi-omics data, precise clinical evaluation. Scope of AI in India to correct the human errors in the clinics. AI has strengthened the belief that having machines solve problems that humans typically solve using naturally intelligence. Robotics and dentistry is also upcoming day by day. Advantages of AI for the reduction of human error used in daily application, faster decision, available 24/7 for medical imaging, drug discovery, improved disease diagnosis and treatment. There are some disadvantages of AI also for the increased cost, few practice programmers, few practical products have reached the market yet. Privacy and security, and most importantly, can be a cause of unemployment, lack of creativity. From this, we conclude that a clear understanding of the techniques and concepts of AI surely have an advantage in the coming future. So AI is not a myth, but a future in the dentistry. Thank you, everyone.
Yes, thank you for your presentation. Our next presenter is Urjita Kulle. Are you there?
Yes, ma'am.
Okay.
Good evening. Myself, Urjita Kulle, third-year student from MIDSR Dental College, Latur. Here before you to present on histopathologic predictors of survival and recurrence of oral squamous cell carcinoma. Oral squamous cell carcinoma is known to be the most common oral malignancy occurring in the oral cavity and is reported to account about 90% of all cancers occurring in the oral cavity. It represents the poorer prognosis with 51.2% of overall survival rate and 59.2% of disease-specific survival rate. It is known to have a multifactorial etiology including smoking, alcohol consumption, genetic predisposition, trauma to the mucosa, diet and dietary deficiencies like vitamin A, C, E, and iron, and maybe HPV 16. The common site involves tongue, mainly the lateral borders, floor of the mouth, alveolar mucosa, buccal mucosa, gingiva. Persistent ulcers, pain are the symptoms of oral squamous cell carcinoma. Histopathology plays an important role in oral squamous cell carcinoma, like diagnosis, prognosis, and treatment planning. As known, it is a gold standard for the diagnosis. Understanding various histopathologic parameters is essential for assessing the aggressiveness of oral squamous cell carcinoma and predicting the patient outcomes. Histopathological grading system, surgical margin, tumor invasion are various key histopathologic features. So now let's begin with the tumor grading. Tumor grading assesses how much the tumor cells resemble to the normal cells in appearance and function and indicates the level of differentiation and aggressiveness. The tumor differentiation is done on the basis of histologic grading into well, moderate, and poorly differentiated one. This is the slide showing well-differentiated squamous cell carcinoma showing abundant keratinization. Moderately differentiated shows minimal keratinization, and poorly differentiated one shows reduced keratinization with the high mitotic activity. The prognostic implications is that the well-differentiated shows the good prognosis and poorly differentiated shows the bad prognosis. The tumor thickness, it is measured from the surface of the tumor to its deepest point. So here the green line represents the tumor thickness, and if the tumor is more than 4 mm in thickness, these are associated with the higher risk of local recurrence and metastasis. The depth of invasion is measured from the basement membrane of the closest adjacent normal mucosa to its deepest point of tumor invasion. So here, the red line represents the depth of invasion. The surgical margins of resection are basically clear, positive, and closed. The perineural invasion is identified by the presence of tumor cells along the nerve bundles on microscopic examination, and it is strongly associated with the local recurrence and lower overall survival rate. So this is the microscopic slide showing perineural invasion. The lymphovascular invasion is typically seen as tumor emboli within the lymphatic spaces on histologic sections, and it is one of the strong predictor of lesional lymph node metastasis and distant spread. The patterns of invasion are infiltrative and non-infiltrative, like cohesive and non-cohesive. The infiltrative one shows associated with the higher risk of local recurrence and poorer prognosis. The extracapsular spread is identified by the presence of tumor cells breaking through the lymph node capsule and is one of the strongest predictors of regional recurrence and metastasis. There are various prognostic models and staging systems that helps to integrate various histopathologic and clinical parameters to stratify the patients based on risk and guide management, involving TNA staging system, Broders classification, Ryan's grading system, Brandwein-Gensler risk model, etc. Understanding histopathologic predictors is integral to optimizing clinical outcomes for OSCC patients, involving treatment planning, surgical management, adjuvant therapies, and target therapies. The patient prognostication involves risk assessment and survival strategies. Then we'll do follow-up and survival strategies. We will do monitoring the recurrence, quality of life considerations. Thereby, I summarize histopathologic predictors are essential for assessing the prognosis and guiding the management of OSCC. And to enhance the chances of patient survival, we should monitor and close observance and mandatory follow-ups are necessary. Thank you.
Thank you for that presentation. And just to remind everyone that you need to vote at the link that is given on the top of the chat. It's pinned to the top. And also to request you, if you have not done it before, and if you are new here, to subscribe to the channel, because besides having things like this competition, we regularly have free interactive lectures in oral pathology, oral medicine, oral radiology, and oral surgery, and a number of general topics. So it will be very useful for you if you are a dentist or in any of the specialties. So please do subscribe. Okay, I'm getting my who's the next person is logged in from two places? Who's the next person is logged in from two places?
Hello?
Mubasshireen, yes, you are logged in from two places, or your YouTube is on. Yes, you are logged in from two places,
Okay,
or your
ma'am.
YouTube is on.
I have logged out, ma'am.
Now let's see. Okay, now it's fine. Let's see. Yeah, you can
Fine?
share.
I can
Yeah,
share my
you can share. Okay, I'm starting your time. Okay, I'm starting your time.
Yes. Good evening, ma'am. Good evening, everyone. I'm Mubasshireen, an undergraduate student, and together today we are going to explore why business skills are essential in dental education. So let's begin. How many of us see multiple dental clinics on a single street and wonder whether every single one of them makes the cut? How many of us know skilled dentists who struggle with the business side of practice? We'll leave the answers to you. An average dental student graduates with minimum business knowledge, yet 80% of them will own or manage a practice. Another statistics says that 50% of practices fail within the first 5 years of setup. Unfortunately, not an exaggeration. To put this more clearly, I'll present to you two case scenarios. First, Dr. Sara, an excellent clinician with a passion for patient care. But despite her clinical skills, she found herself overwhelmed with business aspect of practice. Let's see how. Firstly, she overestimated patient volume, leading to cash flow issues. She failed to set aside funds for emergency expenses such as failure of equipment, etc. She did not have a formal marketing plan, which led to longer waiting lines and eventually frustrated patients. I have yet another case scenario for you if this was not convincing enough. Dr. Lee. Dr. Lee, on the other hand, was a successful established clinician, yet he struggled with stability in his practice with the onset of the pandemic. With the onset of pandemic, the patient inflow reduced, decreasing the revenue. The pandemic also required safety protocols, management, and adjusting to reduce staff, which he failed to implement efficiently. Now, the problems collectively faced by these clinicians were poor pricing strategy, poor financial management, scheduling, and difficulty in scaling practice. In addition to this, the budding dentist also faced issues such as being uninformed or unaware of the regulatory requirements, insurance licensing, and employment laws. They may inadvertently violate them, leading to financial and legal repercussions. All this can be avoided if interdisciplinary learning is incorporated into dental education at the very undergraduate level. How can we do this? This can be done by introducing auxiliary courses on business management, human resources, relevant laws into the curriculum. Regular workshops, seminars, and webinars can be held. We can leverage the experience of an alumni, a successful alumni, in offering practical advices and motivating the students to learn. By incorporating these steps, universities can equip the students, the future dentists, with skills they'll require to run a practice efficiently, ethically, thereby enhancing their ability to serve the patient and the broader community. Business skills are important for a dentist, but it should never overshadow the primary clinical and noble responsibility of providing high quality patient care. With this, I conclude. Thank you for the opportunity. Thank you, ma'am.
Thank you for the presentation. Thank you for the presentation. We go on with the next. All right. Next is Miss Prachi Ladke. Are you there? Yeah. Okay.
Good evening, everyone. Myself, Prachi Ladke. I am from MIDSR Dental College, Latu, studying in third year BDS, and today I am going to present on the integrity role of in cancer. This will begin with what is immunity. Immunity is the body's ability to protect itself against the invading pathogens such as bacteria, viruses. And immunity is our first line of defense mechanism against the foreign substances. So, the immune has three main roles. The immune can protect the host from tumor
Miss
caused by
Prachi,
violence by removing
Miss
Yes,
Prachi,
ma'am.
your voice is breaking. So what you
Yes,
do
ma'am.
is you turn off your camera.
Okay.
Just turn off your camera so you will have more bandwidth for your voice.
Now, ma'am, I'm audible.
Yes, you're audible now. But
I'm
you
audible,
turned
ma'am.
off your sharing. Your screen sharing is gone. Okay. You can start.
Yes, ma'am. To prevent tumors, yes, ma'am. To prevent tumors, the immune system has three main roles. The immune system can protect the host from tumors caused by the virus by removing or suppressing the viral infections. Rapid elimination of pathogens and rapid resolution of inflammation can prevent the establishment of tumor-prone inflammatory environment. Third is that the immune system can specifically identify and eliminate tumor cell based on their expression of antigen or tumor-specific molecules induced by a cell stress. The third process is called as tumor immunosurveillance. The next is the phases of cancer immunoediting. So what is the immunoediting? Immunoediting is the body's mechanism against the cancer and is described as a relationship between the tumor cells and the immune system. As we know that the immunoediting has the three main phases. The first phase is the elimination phase. Second phase is the equilibrium, and the third phase is the escape phase. As we can see in the given chart, how the normal tissues are converted to the transforms, and they are passes to these yes, and then it's converted to tumor growth promotion. The next phase in the immunoediting is the elimination phase. The elimination phase is the hallmark, is the original concept in cancer immunoediting, and that is the system work together to destroy the developing tumor. The immunity has the four main steps. This is tumor cell recognition. In this, the initiation of anti-tumor response. It then converted into the production of pro-inflammatory molecules. Then it recruitment at tumor site. Then this leads to the correction of the macrophages, natural killer cells, T lymphocyte, cytokinins, which leads to the further interaction between the T lymphocyte or natural killer cells, leads to progression of anti-tumor immune response, production of interferon gamma, that is the induced local production of chemokines that recreate more cells of innate immune system to tumor. The second steps in the equilibrium is the dendritic cell maturing. It is the interferon gamma release at tumor site, which leads to the release of the N metabolism, the tumoricidal products, activation of the anti-proliferative pro-apoptotic angiostatic processes. The third phase in the immunoediting, the T cell generation specific to tumor antigen, the recruitment of dendritic cells to the target's Dangler sites, which get activated by the exposure to cytokines acquired tumor antigen by the direct or indirect method. So further, these antigens bearing material dendritic cells migrate to lymph nodes. Then is activation of the tumor specific CD4 plus T cells, facilitate development of CD8 plus cytotoxic T cells. Step 4 is the rotating tumor antigen specific to T lymphocytes to the tumor site. Complete elimination of tumor by host by means of tumor-specific adaptive immune response. Then it leads to the CD4 plus and CD8 plus T cell participate in killing antigen positive tumor cells. The next phase in the tumor cancer immunoediting is the equilibrium phase. In this phase, the tumor cells variants become resistant to the immune attack, and it is the longest phase in the cancer immunoediting, and it may be remain for the many years in the human beings. The third and the last phase in the cancer immunoediting is the phase of escape. In this phase, there are three different strategies to get over tumor immunity. That is the lack of recognition, lack of susceptibility, induction of immune dysfunction. Thank you for your time, ma'am.
Yes, thank you for your presentation. Our next presenter is Ms. Bhakti Porwal. Are you there? Okay.
Video. Hi, ma'am. Let's start.
Yes, please.
Good evening, everybody. Myself, Bhakti Porwal. I am third year student studying at MIDSR Dental College, Latur. So my topic is emerging trends in oral pathology. Field of oral pathology is constantly evolving. It is driven by advancements in technology, scientific research, and deeper understanding of oral diseases. Rise in requirement of these trends is shaped by factors such as increased prevalence of oral diseases, aging of population, disparities in access to care, affordability concerns, etc. My presentation explores key emerging trends which shape future of oral pathology. They are molecular pathology and genomics, digital pathology and AI integration, biomarkers in diagnosis and prognosis, immunotherapy in oral cancer, telepathology and 3D printing, focus on prevention of oral disease. First, we will see molecular pathology in oral diseases. It focuses on the study of genetic mutations and molecular changes in oral tissues. Several techniques has been discovered such as PCR, that is polymerase chain reaction. It amplifies DNA sequences to detect mutations. Another one is fluorescence in situ hybridization. It detects specific DNA sequences in tissues. Thus, it helps to detect the defected gene and study the cause of oral disease. The most commonly used technique is NGS, that is next generation sequencing, which provides a comprehensive analysis of genetic alterations. It shows rapid and efficient accuracy as well as it is cost effective and detect rare variants. Applications. It helps to identify genetic predisposition, early detection of oral cancers, and personalized treatment plan. Gene editing or gene therapy is also practiced recently using CRISPR-Cas9 system to correct genetic disorders. Then secondly, we'll see digital pathology and AI integration. It involves image acquisition in which high resolution digital scanning of microscopic slides for analysis and storage is done. Then AI powered analysis in which automated image analysis using AI for diagnosis, prognosis and treatment planning is done. So we will see here is an overview of digital pathology associated with AI. After the biopsy, tissue sample is processed and molecular images are obtained. With the help of visualization tools, images are evaluated by respective consultants and reviewed by the expertise in the field. Further, AI tools and machine learning add speed, accessibility, and accuracy to the diagnosis. Later on, we will see biomarkers in diagnosis and prognosis of oral diseases. They are biological molecules found in blood, tissues, or other body that indicate disease state. It have types are genomic, proteomic, and epigenetic biomarkers. They help to detect early oral cancers, precancerous lesions, as well as periodontal disease. Then immunotherapy in oral cancer. Immunotherapy uses the body's immune system to fight against cancer. There are various types of like chimeric antigen receptor T cell therapy, etc. And 3D printing. Telepathology involves diagnosis and studying disease remotely using telecommunications, enabling remote consultations and educations. It improves access to expert pathology services in under-reserved area. This technology enhances diagnostic accuracy and reduces delays in patient care. Now in 3D printing, it creates detailed model for tumor visualization, surgical planning, and patient education. It has proven invaluable complex surgeries and further advancements using bioprinting for regeneration and tailored treatment. So conclusion and future outlook, integration of molecular pathology and biomarkers for tailored treatments, and it is continued with AI tools for diagnostics. It revolutionized early detection, diagnosis, and treatment of oral diseases. It is a paving way for more personalized and precise care, as well as it enhances quality of oral pathology. Thank you, ma'am.
Thank you for your presentation. Our next presenter is Ms. Priyanka B. Mane. Are you there? Yeah, okay.
Hello, everyone. Can I start, ma'am? I'm audible?
Yes, start.
Yeah. Hello, everyone. Myself, Priyanka B. Mane. I'm studying in first year BDS Dental College, Gulbarga.
So out of box, I have chosen the like very general topic called as social media, which is we are very well known about that. So the title is like social media, the double-edged sword. So when I talk about the social media, I have the both love and hate relationship when it comes to social media. The hate is the constant logging in and checking on the people and comparing myself to them. But the one thing which I really love about that is the mindless humor that it gives to me. I know I'm not the only one who thinks about like that. Many thoughts like is social media good, bad? Many things randomly comes. But to be honest, to say one thing is social media has more benefit level. It helps us to keep update of the world. It helps us to be updated on our friends, families. Not only like a period of a time, we can get instantly about knowing about them. Like there are many people who also even earn a healthy amount of money at social media, and there are people who even get the love of their life on social media as well. Apart from talking about the personal life, when we talk about the dentistry, we all know there are many dental practitioners who upload their educational videos, practice videos on social media in order to help us, like just like their peers and the students, like dental students, just like you and me. Apart from that, they help us to how to handle the patient, and even the virtual conversation we can be done with a mentor, the one we are having just right now here. Apart from that, social media helps us like for the communication skill, for the knowledge increasement, and to be honest, it also helps in increasing the bar level of an education system. And we know that there are other dental practitioners who use such a social media platform to market their clinics, their conferences, their workshops, and even the one competition we are right now having on online as well. The motive of this is to have the broad spectrum of a people to get to know them, what really dental services, what kind of dental services we are providing, and what kind of things we are literally trying to give them, by which we have been attracted in number of patients. When we talk about something good, so the bad also accompanies it the same way. There are people who randomly follow some websites without having the proper prior information about that. Because just following is not the one thing, they even apply it and meditate about it on their health, which is not only bad, but it's also a very like bad, which increases the severe issues to them. Talking about one's personality, social media has been engulfing some people's personality as well to cope up with the trends, the numbers, the followers. We rush into those things. But social media is an evolving thing, so it's going nowhere. So obviously, the one thing we have to do is to balance it. There are people who only post go which the things which are looks good and sounds good. So we have to have that differentiation of and have what's really good and what is the fabricated story they show on the social media. So as before, I have mentioned it in my resume that before the social media has entered into our life, the adage was to think before you speak, but now the adage has become think before you tweet, upload, or click, or post anything. I hope I have tried to give enough knowledge about social media, and hope we understand what needs to be followed and what needs to be not to be followed. There are two sides of a coin. It has the good and the bad side as well. By saying this, I, Priyanka Mane, signing off. Thank you so much for listening. Thank you, ma'am.
Our next presenter is Mr. Viren Loda.
Yes, ma'am.
Yeah. Are you sharing a screen?
Yes, ma'am.
Okay.
Good evening, everyone. To begin my presentation, I'd like to ask you, are all leukoplakia reversible? Let's ponder on this for a few minutes. I'm Viren Loda, an intern at Krishnadevaraya College of Dental Sciences. Now, if you, like me, jumped out of your seat to say yes, well, then hopefully my presentation will be of some use to you. But if you said no, then please bear with me and give no spoilers. Leukoplakia. What is leukoplakia? Leukoplakia is a white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. This definition itself of leukoplakia underwent many changes as given by WHO, Axel, and Pinbo. The established etiological factor is the use of tobacco, and hence our treatments revolve around cessation of habit. And we have inherited the idea that leukoplakia is reversible. Leukoplakia is classified into homogeneous and non-homogeneous, and it was largely believed that homogeneous variety of leukoplakia is generally reversible. But what's the catch? Are these lesions so straightforward, or do we see them continuously breaking their own barriers? Proliferative verrucous leukoplakia, a lesion described by Hansen in 1985. Proliferative, meaning it has the potential to enlarge, develop, and affect new areas. Verrucous, referring to its rough body texture. PVL stood apart from other leukoplakias because of its clinical features. It was seen in non-smokers, 70% being women and 30% being men. It was seen from the 5th decade onwards on the gingiva, buccal mucosa, and lateral border of the tongue. It had an uncertain etiology. But what is even more concerning is its malignant transformation. PVL showed progression to oral squamous cell carcinoma or oral verrucous carcinoma. Its transformation rate of almost 80 to 100% within 4 years is the highest. The underlying mechanism is the mutation of P16INK4A and P16ARG, the cell cycle regulatory genes. And it was believed that patients who develop PVL with dysplasia are at a higher risk of developing primary OSCC, which was explained by field cancerization theory. So we see that we have a leukoplakia with peculiar clinical features and dangerous malignant transformation. Therefore, it becomes important we understand how to diagnose this. The diagnostic criteria put forward by Villa et al. Says the lesion must be white keratotic, it should be multifocal, or it must be a single lesion involving an area of more than 4 centimeters. It must progress or expand in size, and histopathologically, there must be hyperkeratosis, parakeratosis, atrophy, or acanthosis, or even verrucous hyperplasia. We must now understand that there were also other diagnostic criteria put forward by various authors. But what is more critical is that we understand the deception of PVL. We see that the clinical picture initially is only of a plaque-like lesion, where only full-blown cases come out as verrucous. Histopathologically, there's only mild dysplasia, ringing no alarm bells. And at such cases, when we put patients on recall, we see that new areas are affected and there is recurrence. So in short, it's a lesion with simple presentation with killer instincts. Now we see that PVL differs from conventional leukoplakia by being not associated with tobacco use, having the highest malignant transformation and very high recurrence of over 70%. To conclude, I'd like to say that proliferative verrucous leukoplakia is seen in older women. It is a persistent leukoplakia which has a tendency to progress into squamous carcinoma. It resists attempts at therapy and always recurs. So, do you still think are all leukoplakia reversible? Thank you.
Thank you for your presentation. And we go on with our next, Dr. Farman Basha.
Ma'am, am I
Yes,
audible?
are you there? Yes, you're audible.
Can I
Are you
proceed?
sharing any slides?
No, ma'am.
Okay, then I'm starting your time. You can start.
Good evening, everyone. Myself, Farman, and today I'm here to talk about a paradigm shift in ethnodentistry, integrating ancient wisdom into modern dental therapies. Ethnodentistry is the study of traditional dental practices that utilizes indigenous herbs. So India is a rich source of many herbs. In recent years, there have been a growing interest in herbal derived product. Many dentifrices in the market that publicating that there is a herb extract included in them. These herbal therapeutics actually this offer a several advantages as they have few side effects. They are non-toxic, they are biodegradable and more affordable than compared to the synthetic alternatives. So let us discuss some indigenous herbs which are already in the use of dentistry through various way in the household remedies like turmeric. Turmeric is known for treating the gingivitis and periodontitis. It also reduces the oral pain and healing the wound. When it comes to lemongrass, it is used in mouthwashes to remove the plaque. Peppermint, it treats the periodontitis, gingivitis, halitosis, and also it relieves the toothaches. When it comes to bitter gourd also helps in the treating the gum inflammation. Fenugreek, which we know it is used for the treating the oral ulcer, sore gums and inflammation, and also it reduces the bacteria. Cinnamon, it prevents the bad breath, reduces the oral bacteria. Guava leaves, especially guava leaves, are used to treat the toothache. Guava stem also is used as a brush when it also reduces the gum inflammation, dental plaque, and prevent gingivitis. Cloves, as we know that it is used in the root canal treatment. Clove oil is added in the dental cement. It also relieves the toothache. It controls the bad breath. When it comes to the neem usually cleans the teeth, whitens the teeth, which is used in common in our country. The neem stems. It also relieves bad breath. It relieves tooth pain also and prevents gingivitis. When it comes to aloe vera has a much uses. Like it treats the aphthous ulcer, it treats the lichen planus and also plaque-induced gingivitis. The main use is it causes remineralization of teeth and also leads to the wound healing. Tripala. Tripala is also used as root canal irrigant. When it comes to holy basil, tulsi, it treats the oral submucous fibrosis, oral ulcer. It also prevents bad breath and dental caries. Pomegranate, the fruit which we used to have. This fruit, as per the research, it has natural fluoride in it. It strengthens the enamel. It fights and prevents the gum bleeding. When it comes to the green tea, it also found as useful as it causes the remineralization of teeth. So the extracts of this are being like trying to be added in the form of like essential oils or various way. Like even what we neglect like curry leaf. Curry leaf also found to be useful on strengthening the gums and teeth. It also removed bad odor. Garlic used to ease the tooth pain and prevents the tooth decay. Black pepper also relieves the toothache and oral infection. Amla means it strengthens the gums and promotes healing. Betel leaf, it is used for the bleaching the tooth and it prevents the mouth abscess. Ginger used to treat the gum infection and also it freshens the breath. Usually what happens is these herbs extracts are added through like essential oils and various in the various dentifrices which are is been added. In the conclusion, the future of ethnodentistry holds immense possibilities for advancing the patient care, exploring the scope of dental medicine. There are many more herbs to be found out. When compared to the chemicals, they are having this less side effect. So there need to be a more research and standardization method to the. Thank you.
Thank you for the presentation. So we have finished the third group of presenters and now we will move on to the fourth group. Just reminding everyone, if you like the presentations, please hit like. Also hit the subscribe if you're not subscribed to the channel. And also definitely go and vote on the link that is given at the top of the chat. Now coming with our fourth group, the next presenter is Kezia Sunny.
Good afternoon, all. Myself, Kezia Sunny, a third-year BDS student of PMNM Dental College and Hospital, Bagalkot. Today, my topic is about the difficulties or challenges faced by the students towards the learning of oral pathology and how can you make it interesting. Oral and maxillofacial pathology is a specialty of dentistry that investigates the cause, the nature, and effects of oral disease that affects the oral and maxillofacial region. An understanding of which is essential for diagnosis and for development of rational treatment and preventive measures. Oral pathology is a core subject that links between the science, clinical dentistry, and the medicine. So this is essential for the histological basis for identifying various numerous dental treatment procedure. Furthermore, the oral pathology contributes significantly to the public health by identifying and controlling the disease that affect the large population. It plays a very important role in the epidemiological studies to track the disease that spread with effectiveness of public health and interventions. Coming to the challenges that is faced by the students. One is the complexity of the subject. Oral pathology involves understanding the intricate details of each lesion's histopathology and the preventive measures treatment, which could be overwhelming to the students. Second is the volume of information. The vast amount of information and the need to memorize each particular disease, their characteristic features, could be daunting to the student. Next is the important one, the integration with clinical correlation. Students often feel struggle to connect their theoretical knowledge with that of their practical knowledge, which may make them challenging to see the relevance of what they are learning. So one of the primary challenges that students face is the integrating the theoretical knowledge with that of their practical skills. Oral pathology is a subject which requires deep understanding of both macroscopic as well as microscopic features. Additionally, some terminologies, classifications, and diagnostic methods constantly keep changing, where this making more confusions to the students, and students must be updated with the latest advancement. Now, how can we make it more interesting? By incorporating interactive learning. Integrating in interactive learning tools like digital microscopy, visual case study presentation, and softwares can enhance the learning. Second is by clinical correlation. Regularly taking clinical case studies and real life scenarios help the students with their practical skills. The third is guest lecturers and workshops. Inviting experienced guest lecturers and hands-on workshops can provide valuable insights and inspiration to the students. Next is the multimedia resources. There are a lot of multimedia around us, like animations, video, and online platform, which can help the students to retain and visualize the informations. Next is research opportunities. Encouraging the students to participate in oral pathology related projects could spark an interest in students and help to know deeper aspects of the concept. Mentors can also incorporate the problem-based learning into the curriculum. This method fosters critical thinking, collaborations, and clinical practical applications. To conclude with, oral pathology is a paramount to the future dental professionals. While the subject may be slightly challenging, but enveloping or incorporating innovative teaching methods can make learning both enjoyable and impactful. Thank you.
Right, thank you for the presentation. Our next presenter is Somita Bhattacharya.
Good afternoon. I'd like to share my screen.
Yeah, go ahead.
Good afternoon. Myself, Dr. Shomita Bhattacharya, first year PGT, Oral and Maxillofacial Pathology Department from Krishna Devaraya College of Dental Sciences and Hospital, Bangalore. The title of my presentation is Pleomorphic Adenoma when Myoepithelial Cells Come to the Ball. As we know, pleomorphic adenoma is the most common benign tumor of salivary glands, which consists 66% of all salivary gland neoplasms. It can have synchronous or metachronous association with other salivary gland neoplasms like Martin's tumor. 90 to 92% of pleomorphic adenoma occurs in major salivary glands, whereas 60% occurs in parotid, 8 to 10% occurs in minor salivary glands, palate being the most common site. It is also called benign mixed tumor because of the dual genesis from myoepithelial and ductal epithelial cells, though actually it is not a truly mixed tumor because it is not derived from more than one germ cell layer. So there are certain differences between this major gland and minor gland pleomorphic adenoma. 90 to 92% occurs in major glands. They are generally larger and nodular, whereas minor gland PAs are 6 to 8% occurs in minor salivary glands. They are generally smaller and they causes localized swelling. Major gland PA, macroscopically, they are encapsulated, and minor glands, they are generally partially capsulated or uncapsulated. Microscopically, if you see, they're less, major gland PAs are less cellular, there's more stroma, there are more of spindle cells or epithelioid myoepithelial cells. Whereas minor gland PA, they're more solid and cellular, there are high proportions of myoepithelial cells, there are more plasmacytoid myoepithelial cells. There are more recurrence rate in major gland PA, whereas they are generally less aggressive. Whereas minor gland PA, their generally recurrence rate is relatively less than major gland, but they are more aggressive and they have greater tendency for perineural invasion. Histopathological components of pleomorphic adenoma shows various spectrums, mainly due to presence of ductal epithelial and myoepithelial cells that gives various stroma. The ductal epithelial cells can be arranged in different patterns like ducts, islands, nest, foci, etc. They can have different cellular morphology like cuboidal, columnar, squamous, oncocytic, and clear cells. Myoepithelial cells, they also have different cellular morphology and they shows different kind of stroma, which we'll be discussing in the later slides. So what are these myoepithelial cells? Normal myoepithelial cells are contractile cells associated with secretory epiphyses. They're also called basket cells. Normal myoepithelial cells, they help in epithelial cell differentiation, contractile function, tumor suppression, etc. The morphological patterns of neoplastic myoepithelial cells results from the interplay of three characteristics: cytological differentiation, extracellular matrix production, and architectural patterns. So neoplastic, when these myoepithelial cells becomes neoplastic, they can show several morphological variants like basaloid, epithelioid, clear cells, spindle cells, plasmacytoid, and squamous differentiation. Neoplastic myoepithelial cells, they give rise to different stroma due to their various secretions like myxoid stroma, chondroid, hyalinized, lipomatous, osseous, chondromyxoid, and fibrous. So the whole story changes when myoepithelial cells enter the ball of pleomorphic adenoma. So there are certain stains, spatial stains, and IHC markers for detection of myoepithelial cells like pancytokeratin, SMA, calponin, P40, etc. But not all the markers are generally expressed together. Hence, a combination of 2 or more markers should be used for confirmation. The suggested initial panel is the use of pancytokeratin, SOC stain, ACE100 protein, P40, and GFAP. So, is there any identification criteria to identify a myoepithelial rich tumor? Actually, there is no percentage presentation or there is no set criteria to categorize myoepithelial rich tumor. It can be only recognized by light microscopy through enzyme histochemistry, spatial stains, and immunohistochemistry. Coming to the prognosis, myoepithelial rich tumor has better prognosis, where myxoid pleomorphic adenoma, they has more recurrence rate because they are generally more likely to spill during the surgery. If a pleomorphic adenoma has chondroid stroma, it is generally benign. If a long-standing tumor has hyalinized stroma, it have a greater tendency to grow malignant, and predominantly cellular tumor have a more chance for malignant transformation. Now the question is, are these neoplastic myoepithelial cells host-friendly? In neoplastic state, myoepithelial cells has lower proliferation rates than basal type of epithelial cells and secretes excess substance that inhibits tissue invasion and metastasis. In intraductal carcinoma, myoepithelial cells separate the malignant epithelial cells from stromal environment, forming a barrier between the transformed cells and basal membrane. But at some point, the cells break this myoepithelial.
Sorry, I have to interrupt you. Your time is up.
Yes, ma'am. Okay, these are my takeaway points. Thank you. Have a good day.
Right, going with our thank you for the presentation, and going with our next presenter, Dr. Anu Gujjar. Are you there? Dr. Anu? Okay, our next presenter is Ayesha Haanee.
Yes, ma'am, I'm here.
Okay.
I'll just share my screen.
Okay.
Good evening, everyone. Today, I'll be speaking on the topic Beyond the Smile, the psychological toll of oral and maxillofacial diseases. Let me tell you a story. There was a 30-year-old patient who had a history of severe dental anxiety stemming from traumatic dental experiences during childhood. He avoided dental visits for years, leading to significant oral health issues. The fear of dental procedures became overwhelming, leading to panic attacks at the thought of visiting a dentist. His poor oral health affected his self esteem, causing him to avoid close interactions with others. This anxiety extended into other areas of his life, causing general anxiety disorder. What is oral and maxillofacial pathology about? It refers to the study of diseases of the mouth, jaws, and related structures such as salivary glands, temporomandibular joints, facial muscles, and perioral skin. The oral and maxillofacial diseases include tumors, tooth decay, or any facial trauma, and so on. Now, patients receiving treatment for these diseases were reported to have higher levels of depression, anxiety, or dental phobia. Why? Due to intensified perception of dental pain, regardless of the degree of oral pathology. So, it is vital to understand the connection between the health of the mouth and that of the mind. What do we think could be the psychological impacts on these patients? As we know, the significance of self esteem lies in the way we are and the sense of our personal worth. Studies have shown that individuals with these diseases often present with signs of low self esteem. This is often linked with the concerns regarding recovery and the stretch of treatment course. Moreover, following maxillofacial trauma, the individual may suffer facial deformations and clinical and chronic facial pain. Oftentimes, concern is dedicated to the physical aspect of maxillofacial trauma. These conditions can lead to social withdrawal, bullying, or discrimination, which contributes to social isolation and stigma. The mental troubles may lead to joblessness, illiteracy, and poor societal support. Subsequently, the subthreshold symptoms may lead to problem solving dilemmas and deprived management of the conditions. Other symptoms that may complicate the dilemma include normative reactions to sadness, anguish over losses, complications from medications, and exhaustion from treatment. Now, when these emotional and behavioral disorders remain untreated, it leads to deprived social performance, job related fiasco, drug and substance abuse. Based on the current mode of management, the management should be a multidisciplinary approach. What do you think can be done? Here are some ideas. Innovative, cost effective programs which can integrate medical and psychological care should be implemented in hospitals. Interventions like motivational interviewing to assist patients to promote positive behavioral changes and refining long term outcomes of the treatment can be done. Educating surgeons on behavioral issues and offering easily accessible guides for swift observation of these problems.
Developing collaborative bonds wherein surgeon and mental health professionals will formulate a treatment plan that would address surgical and psychological needs. Depression puts an individual at more danger of suicidal tendencies, reduced treatment compliance, and social isolation. In such cases, quality of life and recovery from maxillofacial trauma are often compromised. Our job is not only to heal the wound, but also to heal the mind. With this, I end my session. Thank you.
Thank you very much for the presentation. Just to remind everybody, you need to vote at the link which is given on top of the chat. The voting is on our website. It is not here. Here you're just basically adding a comment so we know that you're attending. Our next presenter is Bhavesh Krish Sancheti.
Yes, am I audible?
Yes, you are.
So let me allow to share a screen. Okay.
Okay, I'm starting your time.
Yes. So good evening, respected dignitaries, my fellow participants. Myself, Bhavesh Giri Sancheti from third year BDS, MIDSA Dental College, Latur. Today I'll be presenting a topic before you, that is gene therapy as a management of oral squamous cell carcinoma. So it is guided by Dr. Smita Chowre, faculty member of MIDSA Dental College, Latur. Concept we will peep into is introduction, etiological factors, then it is etiological factors, basically history and excuse me. Hello.
Yeah.
Ma'am, just a second. Okay, huh. History and concept history and concept of gene therapy, types and mode of delivery of therapy, gene technique of gene therapy in oral squamous cell carcinoma, new trends, advantages, disadvantage, and conclusion. To basically, ma'am, is my PPT visible?
It's visible, yes.
Okay, ma'am. Just a second. I'm not able to get internet. Ma'am, may I start?
Yeah, go ahead.
Okay. So, introduction, oral squamous cell carcinoma is the sixth most common oral cancer worldwide. It's associated with basically genetic mutations. The patient suffering from cancer usually remains immune to standard therapies such as surgical excisions, radiotherapy, and chemotherapies. So, basically, gene therapy is an boon. Okay, it will peep into it, and gene therapy has been introduced in arena of biomedicine to improve the treatment modality of oral squamous cell carcinoma. To summarize, we have factors like tobacco and alcohol in its product, which are going to mutate the genes controlling apoptosis and cell growth. Here comes gene therapy. What it does is it acts as a therapeutic. It inculcates a therapeutic gene which is useful to cope with and relapse the disease. So the etiological factors are alcohol, tobacco, dietary factors, sedentary lifestyle, early exposure of the youngsters, immune deficiency, viral infections like HPV virus. These all will lead to oral cell squamous cell carcinoma. Now the history behind it is the history and concept behind the gene therapy. So pioneer work was done by Lederberg and Edward. Concept is to work on notation of modifying the genetic material of a living cell. Now how we can do it? Basically we have two types: somatic cell gene therapy and germline, out of which germline gene therapy is more preferred. Mode of delivery of this therapeutic gene can be ex vivo or in vivo. Ex vivo is implanted into the cell diseased tissue outside the body, which is not used much. In vivo may we have direct implanted into the body of the diseased site. Here comes the role of vector as a vehicle. We can use either viral or non-viral vector. In viral we have adenoviruses, and non-viral we have gene guns and electrophoresis. Now, technique of gene therapy. 7 techniques are employed in gene therapy. I'll quickly summarize them. The first is additional gene therapy. The second is gene excision therapy. Third is antisense RNA. Next is immunotherapy, suicide gene therapy, oncolytic, and gene therapy for tumor of angiogenesis. Now, what are the new trends inculcated in gene therapy in order to treat oral squamous cell carcinoma? Basically, it induces use of intervention of nanoparticles via gene therapy. So first objective is upregulation of gene inhibiting tumor growth or downregulation of gene which promotes tumor growth. And the second most objective is suicide gene therapy. So what is suicide gene therapy? Suicide gene therapy is the mostly used therapy. Here what we do is the therapeutic gene is introduced into the cell which permits expression of enzyme to transmit a non-toxic drug into a cytotoxic substance, and it will then kill the carcinogenic substance or the cell. And the third objective is delivery of small RNA which targets the drug resistance. Now, what are the advantages? Advantages is it counters the noxious effects of other therapies like chemotherapy and radiotherapy. Advantage is the defective gene is replaced by the therapeutic gene by just a simple procedure which is non-expensive and has a better prognosis. Disadvantages: numerous round of therapy is required, a skillful person is required, and if genome is adversely targeted, it can adversely affect. My conclusion, I can conclude it in basically it has a high scope in future with a decrease in mortality rate, and it can become a reliable treatment option for oral squamous cell carcinoma. Thank you. Thank you very much.
Thank you. Thank you for your presentation. Our next presenter is Ms. Kriti Agarwal. Are you there?
Yes, ma'am.
Okay.
May I begin?
Yes, please.
Hello, everyone. That's Kriti from Navodaya Dental College of Raichur. Today, I'm here to speak about the dental access and insurance to the care, the disparities in the access of the dental care, and also the role of insurance company in shaping out the dental health. Am I visible properly to everyone? You can react me. Over the react, you can react me. Okay, as we all know, health is a permanent, important thing for a human being. Health is a fundamental right of every human being, and oral health is a gateway for the body. So, let me begin with a very beautiful and yet a funny quote for sure. Protect your smile and also your budget. Yet, because we know the dental expenditures are very high and dental insurance, I guess most of you don't have a dental insurance, right? How many of you know about the dental insurance? Okay, so here I am to speak about the dental insurance, access to it, availability, advantages, disadvantages, and much more, and surely terms and conditions. So let me begin. What is the difference between a dental insurance and a medical insurance? Like more often we have heard about the medical insurance. My father paid that insurance, this insurance, we are getting that help with that. We have paid this much money. We just had to pay a little because we had an insurance. But what about dental insurance? Being a dentist, we ourselves don't know what is a dental insurance and how to get it. Yes, it's a major thing of concern to be thought of. So let me start with a very small problem. Like if I get a small caries in my tooth, what will happen if I just go for a normal regular checkup? It will charge me around 500 to 600 for 6 months if I do it on a regular basis. If I don't do it, then what happens? And it will just proceed. It will lead to the caries, and then it will lead to the destruction of the tooth, and then to the root canal treatment. At some time, it will lead to the replacement of a new crown, and in other sometime to a implant for sure. So, what do you would like to go for? Investing around 5 to 600 rupees every 4 to 5 months, or just spending half of your savings in one surgery in a dental thing? So, what I suggest is you, being a dentist, has to promote the dental insurance companies and do it well. And what do you think the major reason that why Indians are not going for a dental insurance companies? The first thing is dental insurance companies thinks that dental insurance is actually the cosmetic treatment, not the dental treatment, because dentistry being itself a specialization in itself. Because we MBBS students study themselves, but in dentistry we have to specialize only about the buccal cavity and everything. So we are well known for a specialization in the dentistry. And in other countries, they are treated like a cosmetic surgeon because everyone wants a very good aesthetic and a good looking smile, right? Everyone, you can react to me. It's an interactive thing, okay? And after that, for sure, the major reason that why people are not getting the thing is before getting any insurance, what they do is they check the physical examination is being done. If they have a chronic disorders or the inherited disorders, they won't give the medical insurance. But when it comes to dental insurance, all the Indians are not actually eligible for getting the insurance because more often people are very much addicted to tobaccos, alcohol, smoking, which of course you know that it will cause very much problem to the buccal cavity. So we are not usually used to that thing. After this, I want to say that there in India we have so many dentists, right? But we don't have the equipments. We don't have the equipments. We don't have the accessibility. We don't have the knowledge. Poor literacy rate because of which people don't know. We don't even have the public what do we say that particular term? Let me remind it for you. Like the popularity is very less when it comes to the dental insurance. People are not aware about the dental insurance. If they are aware of the dental insurance, they need to have a premium thing like premier medical insurance to access for the dental insurance. Then also there are so many terms and conditions. Once you, even if you get the dental insurance, yet you have to like so many problems ahead that you have to have a 24 hours hospital time. Like if you are admitted for more than 24 hours, then only the insurance company will give you the money. And if you are the 5% of the bill will be paid by the insurance company. There should be more than, there should be something like the jaw misalignment, you know, like fractures. If we have a dental insurance, what are the things which we are very happy to get when we have a dental insurance? The thing is, it will be very free, of course very free. That if you have a sudden emergency like any of the fractures, maxillofacial surgeries and all, this will cost us very high and we can't afford them at once. If you have these type of insurance, then you can do it very well. And being a second year undergraduate student, I could try as much as I thought to do. Actually, before doing that, our oral health is actually very much important as like as our physical health also. So I would like to give any queries, if any. Queries, if any. Okay, fine. Life is very short, guys. Smile it till you have your teeth. Okay? Thank you. Thank you, everyone. That's me, Kirti.
Thank you for your presentation. Yes. And we go on with our next, that is Mr. Kailash Moria. Are you there? And the next one is Kritika Patil. Kritika, are you there? What about Mehak Balla?
Yes, ma'am, I'm there. Just a minute, ma'am. I'll present my screen.
Okay.
Just a minute, ma'am.
You can start.
Good evening. My name is Mehak Bhala. I'm a second year undergraduate student from SDM Dental College, Dharwad. My guide is Dr. Kaveri. My topic is oral submucous fibrosis, a juvenile review. Addiction is a family disease. One person uses and the whole family suffers. I was very fascinated when I read about this disease. I just couldn't understand why this disease affects 2 to 4th year of our life. That's 20 to 40 years old. Why does it affect? And later, I realized that the underlying cause is betel nut chewing in childhood. Oral submucous fibrosis is related to the habit of betel nut chewing. When a school survey was done, it was found that kids had betel nut pouches in their bags. This habit has to be stopped. I'll tell you why it has to be stopped. 3 reasons. First is it is irreversible. There is no cure for it and there is no treatment. It can only be prevented in the early stage. Now, we all must be thinking, how do we prevent it? First come first is self. The kid himself or herself has to realize that this habit is not good. I must not eat this. It's hazardous. But how will a kid understand? So school plays a primary role. The school curriculum must incorporate these ideas of teaching the students. Teachers have to be trained. Events have to be conducted, like drawing competitions, skits, and group discussions have to be there. Japanese do it. They do it in a similar fashion. They teach etiquettes, manners, and lifestyle habits, diet in a very similar way. Secondly, this is a digital era, right? So we need to go digital. We need to interview people who have already suffered and they regret consuming betel nut, and we need to put that on social media like Instagram, YouTube. Next comes going to the ground level. On the sachets that might be tobacco or betel nut, always there's a picture. The ingredients are mentioned that this is hazardous to life. Yet people consume, and so are kids doing, right? So we need to understand their physiology, their psychology, come to their level and understand why are they consuming and try to do counseling. Most important is money. Everybody understands the language of money, right? Just look here. There's a packet, 40-gram betel nut packet. If consumed per day, it costs around 60 rupees. For a week, if it's consumed continuously, it costs 420 rupees. Over a period of time for a month, it's 1800 rupees. And compounded for 10 years, it will be 4,03,265. This is only what the kid is consuming. There are additional cost effects as well, right? Like the bills, it can be hospital bills and the family suffering. So all of this, the kid has to know. The kid has to be educated about all of this. Addition to the ill effects, the kid should be educated about money. And most importantly, what will happen if this money is put somewhere else? Now look at the next picture. Kids are taught in school using pictorial representations, right? May that be poems, stories, animals, plants, whatever it is. So we need to show them pictures like this. Like there's a happy family where there's no addiction. The kid doesn't consume anything. The family is happy and the kid is happy. The money is used for the betterment of the family. And the second picture shows where the kid is consuming betel nut. And because of this, there is problems that the family is facing. Now, after this pictorial representation, we need to also tell them that oral submucous fibrosis, if it continues, it will lead to SCC, which is again very dangerous, cannot be treated, and really hazardous. We should also tell them at their ground level, as I mentioned earlier, that if you consume this, people are going to talk bad about you. The surrounding is going to talk bad about you. You're going to have a bad image. People are going to talk about your parents. And no kid likes that, right? So coming down to their psychology is very, very important. To conclude, I would tell that a child's mindset is immature and it has to be correctly molded. It has to be molded in such a manner and trained so that the child understand what is going wrong. It has to be done at an earlier age. It has to be done quicker and sooner. And by whom should it be done? It should be done by teachers and parents. After all, addiction is the only prison where the lock and key lies on the inside. I would repeat, after all, addiction is the only prison where the lock and key lies on the inside. Thank you.
Yes, thank you for the presentation. And with that, we have reached the last. Let's ask, I think, Aastha Jakhar, if you are there, you would like to try your presentation?
Ma'am. Hello, am I audible, ma'am?
Yes, you are.
Okay, ma'am, I'll just share my screen.
Yeah.
Okay, ma'am. Thank you, ma'am.
Yes, start.
Hello, everyone. My name is Aastha Jakhar. I am from RUHS College of Dental Sciences, Jaipur. So my topic is myofascial pain dysfunction syndrome. So what is a myofascial pain? So it is made up of two words, myo plus facial. Myo refers to the muscle and the facial refers to the fascia. So there is a pain of the muscle and along with it, there is an inflammation of the underlying connective tissue. So when we talk about the myofascial pain, it can often be called as the MPDS or myofascial pain dysfunction. It is a regional myogenous pain condition characterized by local firm hypersensitive bands of muscle tissues called as the trigger points, and thereby it can also be called as the myofascial trigger point pain. It results from the hypercontraction of one or more elevator muscles, leading to the pain, tenderness of the muscle, even the TMJ problems and limitation of the mandibular movement. When we look onto the mechanism, so there could be certain etiological factors like the stress, anxiety, bruxism, that causes certain micro and macro trauma to the mucoskeletal system, leading to the muscle pain. That causes the hypertonicity of the muscle, causing muscle fatigue, and there is an accumulation of the metabolic byproducts that causes the lower pain threshold. And this lower pain threshold, it stimulates the chemical and the mechanical mediators, leading to MPDS. So there are certain MTRPs, they are considered as the big mischief in causing the myofascial pain. So there could be of two types, the active and the latent. So these active, they can easily be palpated on the muscle tissues and they appear as a jump sign. And when we see the latent, they are just the nodular. So these trigger points, they can actually, so pain from these trigger points can radiate to maxillary mandibular teeth, tongue, alveolar ridges, palate, frontal temporal region, TMJ, pharynx, ear, and even on the occiput and the lateral side of the mandible. Etiology includes severe bruxism, malocclusion, clenching of jaws, increased sensitivity to pain, anxiety, or stress. So there is a chart showing how the myofascial pain dysfunction proceeds. So it is through the stress, dental irritation that can cause muscular hyperactivity, leading to muscle fatigue and ultimately MPDS. It can also be caused due to muscular overcontraction or extension, along with it due to altered chewing pattern. Now, this altered chewing pattern, this can also be caused as a consequence of MPDS due to occlusal disharmony and internal derangement. Clinical features includes like there is a cardinal symptoms for classic symptoms like pain or discomfort, limited jaw movement, tenderness of the muscle when we palpate the muscle, and there could be joint noises like clicking and snapping. So other common features like it is more common in female on comparing to that of the male with a ratio of 3:1. Pain increases during the time of stress. There could be bilateral, unilateral. There is tenderness of the muscle. Pain may migrate to areas of head, shoulder, or even onto the ear and the neck region. So there is deviation of the jaws on opening, limitation of jaw movement, and clicking sounds. Management. There could be two types of management, like the surgical management and the non-surgical. Non-surgical management, it mainly includes the rest and the diet modification. So this type of management, it is mainly done to limit the jaw movement and to prevent the trigger of the muscle pain. Next, we could have the pharmacological management like the analgesic drugs, where we could have like the NSAIDs. Example is the lidocaine patch, muscle relaxants we can give to the patients. That could be tizanidine, considered as the first line in the treatment. Anticonvulsants, that is pregabalin, gabapentin. Example, it is also considered as a good analgesic, anticonvulsant, and anxiolytic. Trigger point injections may include like the steroids, or we can give the short or the long acting and anesthetics along with botulinum toxin, which is a neurotoxin. So it mainly prevents or reduces the contraction of the muscle. Then we have certain non-pharmacological approaches like dry needling and the laser therapy. They are often done to inactivate the myofascial trigger points. Manual therapy, it increases the blood flow. Along with ultrasound therapy, it is done to reduce the muscle stiffness and pain. Magnetic theory or magnetic therapy or the stimulation, it is just a new or the latest addition. Occlusal splint therapy, they can often be given for the relaxation of masticatory muscle and protection of teeth and the jaws. Then we have the surgical management. It can be done like condylotomy, meniscotomy, arthroscopy, and myotomy for the joints. I've chosen this topic because like we all in daily activities, we can find that there are dear ones, they may suffer from such type of pain. They may have experience in their life, so they can relate with it, and they can know how it can be managed. Thank you so much, ma'am.
Yes, thank you for the presentation. And with that, we have come to the end. Any of those who had missed are now with us? A few of our presenters had missed. Any of them have joined? You can present now.
I can take their names. Dr. Shanmuha Priya, Parul Mehta. No, I'm just asking.
Yeah, correct.
Monika Sharma, Parul Mehta, Dr. Annu Gurjar, Kailash Moria, Kritika Patel. These are the ones who haven't presented.
Yes. I do not think any of them are with us. So now I'm going to request our judges to put on your camera. Yes. It was rather intensive and but very interesting topics, I think.
Yes, very diverse topics,
True, ma'am.
very diverse, right from our
And
pathology.
variety of topics.
Yes, quite.
Right from
So,
our pathology to something interesting, like many of them talked some interesting topics, which is actually interesting for everyone, all the dentists out there, like insurance, dental insurance, then how to be compassionate breaker of news, ethno-dentistry, which is very much in thing with all these grants coming up. So yes, business
And
knowledge,
that too.
how to run dental clinics. Yeah, please go ahead, Koshali.
That too, ma'am, undergraduate students surprisingly did very nicely, like the way they choose the topic, they prepare presentation.
Yes.
Postgraduate students has done good performance, but undergraduate, I'm very happy with, like, what they did is very good.
Yes.
Yes, that is true. It was really amazing to see the range of topics, the presentation, and I must say almost everyone was in time, which is something quite amazing actually.
Yes.
Yes.
Well practiced and well presented. Yes. So before we wrap up, anything any of you want to say specifically? Selvi, you want to say anything more?
No, that is what actually all of them have presented very well. So it has been very close, scoring, maybe this little bit this side, that side. So I think now it all depends upon the public or the people voting for whom. So that is my understanding. Whether it was the postgraduates or the undergraduates, the marking has been, I felt, almost similar. It's in close race,
Yes, it's a close race. I could judge that from just listening. That's true. Yes, very much true. Kushali, you want to say anything?
No, just ma'am, want to thank you for this opportunity. Actually, I'm very happy.
Kushali, you got to sort out your internet.
This presenting like I think actually in Gujarat, ma'am, there is such situation.
Okay.
I don't have like electricity connection also over here.
Okay, that's why you're on your phone. Okay, no worries.
Yes, ma'am. Yes, ma'am. So sorry for the inconvenience, ma'am.
No problem. I just love to hear you, and then your voice breaks, and then I can't hear you. So, okay.
So sorry, ma'am. So sorry.
I also would like to thank Mandana for giving me this opportunity. So it was a very well spent afternoon listening to diverse topics. Yes. So thank you, Mandana.
Thank you both for
Thank
being
you,
here
ma'am.
and always being someone I can count on to do some really hard work. So yes, I knew because I understand listening to almost 40 presentations when you have to be attentive and you have to be fair and you have to judge them is not easy. It's not like just listening. When you are judging, it's much more complex. And I definitely, as always, it was lovely being with you all, but I also thank you very much. And also to everybody who took part, thank you for being there. Thank you to all the teachers who have guided many of the presentations. It was an amazing response. And I thank everyone. And I, of course, thank the audience who have been with us throughout and have been typing their comments. And I hope they have all gone and voted. So, with that, let's wrap this up and hope to see everybody soon. Be safe.
Thank you. Bye-bye.
Bye, everyone. Bye. Yes, the stream is over.
Okay. That